Good morning. Are we on? I don't think we are. Good morning. Oh. All right. Good morning. It's so good to see all of y'all. First of all, let's say happy Thanksgiving week. Appreciate everybody pausing and being here. A couple of things happened that made us kind of have to move this meeting out a little bit. So sorry to bring y'all in on this Monday, but I hope the traffic was easier and better because there are not as many school children on the highways. Let's pause just a minute. Let's start this with a prayer. Dear Heavenly Father, we ask that you come today and open our hearts, our eyes, our ears, our minds, to please listen to what the purpose of this discussion really is. We thank you for the opportunity of this study committee once again as we go into the final meeting, and are grateful for all who work so hard in the field to help our children have the best beginnings and the best lives ahead. Dear Lord, help us to come together with these final presentations and with a heart to really begin to find solutions. We ask that you be with all of us and help us to travel safely and to enjoy this wonderful week with family and friends. In your name we pray, amen. Okay, so here we are. It's finally meeting 5. Thank you so much for making it a priority in each of your days. I understand Representative Dickerson will have to be at work today, so this is who will be listening today. But the wonderful thing is that she can catch up just as others can that can't be here on this day. So we will get right into this. Today, during this committee, we've heard from a range of professionals who work directly with our children on why they believe social emotional health for infants and toddlers is so critical. We're excited to hear from our neighbors in Alabama today who have already begun focusing on infants and toddlers in a very cohesive and statewide manner, which is so very important. Today's objective will be to tie up all of the loose ends from previous meetings and underscore the important opportunities for how we can each move forward as a state in this work. Our first presenter is Melissa Carter, Executive Director for the Barton Child Law and Policy Center. Melissa is a professor will provide the context for the Family First Prevention Services Act, which aims to provide services to families who are at risk of entering the child welfare system. By providing reimbursement for mental health services, substance use treatment, and in-home parenting skill training, there is quite often the possibility that they might not enter that system. Professor Carter's work focuses on the legal rights and interests of children and youth involved with juvenile court, child welfare, juvenile justice systems. She has represented the interest of abused, neglected, and court-involved children in policy and legislative manners at the local, state, and federal levels, contributing to the drafting and passage of dozens of pieces of very important and life-affecting legislation. Thank you for being with us this morning.
Well, good morning, Madam Chair. Is that a good audio for you? Okay, good morning. Better? Great, thank you all. Good morning, Madam Chair, members of the House Study Committee. Thank you so much for the invitation to be here with you today, and I would be remiss if I didn't credit all of you with the passage of those pieces of legislation on which I've had the privilege to work. So thank you for your leadership today and always. I was asked to address the Family First Prevention Services Act, which I suppose many of you, or I'm going to assume many of you have already heard about. It is a large and comprehensive piece of federal legislation. Congress acts comprehensively in the area of child welfare about every decade to decade and a half. So this is the most recent example of that. And given the time that we have and also the focus of your work here within this study committee, I'm really only going to focus on a particular part of it, and that is with respect to the prevention services opportunity that this act unlocks. So for those of you who have some exposure to it, we won't be talking as much about the congregate care restrictions and the qualified residential treatment program and the other things giving our work some challenge right now, just because those aspects of the federal legislation are less relevant given, again, the focus on young children. And so to, let me make sure I can advance this. There we go. So briefly, and I'm not, but I can keep going. Maybe just be a little slow, like we all are on Monday mornings. So real quickly, with respect to the Family First Prevention Services Act broadly, this really is, as I was mentioning, probably one of the most significant pieces of federal child welfare legislation in over a decade. It really has been celebrated as a response to a pretty steady drumbeat for about 2 decades by states for an opportunity to use available federal funding in a more flexible way. So this all orients around a refinancing of the child welfare system, particularly as it relates to the largest federal funding stream supporting foster care. That's Title IV-E of the Social Security Act. So historically, really until the Family First Prevention Services Act, that federal funding has largely been tied, almost exclusively actually, to the removal of children from their homes and the entry and placement of those children in the foster care system. So under Title IV-E, states are eligible or able to seek federal funding or a portion of federal funding reimbursement on a reimbursement basis for the services and placement of children in foster care for eligible children. Family First reorients that opportunity, doesn't take away from the continued funding for foster care and placement and services for children in state custody, but allows for the federal funding to be directed also toward, thank you very much, towards prevention. With some particular caveats. So states will be able to draw down federal reimbursement for certain prevention services, those that are evidence-based, and in certain service categories, including mental health, parenting support, and drug and alcohol treatment. And so we'll talk more about those particularities, but that is the new opportunity. As I mentioned before, just for purposes of being comprehensive, on the back end, still back in our placement side in foster care, there are some limits imposed on federal funding for placement of children in congregate care settings. There are a host of implementation timelines that are being juggled, lots of plates spinning on this, and there will be for quite a while. But the state has set a timeline for implementation as of September 29th of 2020. So we can talk about what that really means to say we'll be implementing by 2020 as we go forward. I mentioned before, this is really orients around a refinancing of the Title IV-E backbone of funding for child welfare. That is the largest federal funding source for child welfare, but important for your consideration of opportunities here in Georgia. That is the 3rd largest funding stream in Georgia. As you might be aware, Georgia's child welfare system is financed a little bit uniquely. There are only a couple of other states that are similarly financed in that we use state and TANF dollars more heavily than we use this entitlement funding stream under the federal Title IV-E opportunity. And of course, whether it's 4E or those other opportunities, there's a state match consideration here. So there does have to be state funding invested in these opportunities. That 4E funding, as I mentioned, currently is available for maintenance payments, the care and services for children in foster care, for also for the administrative costs to manage the child welfare program, and also for training of staff and foster care providers, both in the public sector and through the private agency partners. The new opportunities under Family First are to impose these restrictions, as I mentioned, on congregate care as a way to, in part, free up funding that can be used for these prevention opportunities, again, tied to the use of evidence-based programs and services for children. And those particular children, I should mention this. So this is all part of something larger, just so that you're aware of a federal direction that is shifting somewhat. And that has a lot of support from the child welfare communities across the states, in that the U.S. Children's Bureau has identified 5 particular strategies and being the sort of features of the future child welfare. And these are the kinds of things that the federal government is moving toward. So one is changing the work's focus to prevention, both prevention of maltreatment and also prevention of the unnecessary removal and placement of children in foster care, meaning that we should ask ourselves what opportunities are there for intervening at that early stage to see if we can keep children with their families. I know that this committee has received testimony and is otherwise aware of the traumatic effects of removal, even when it's necessary to remove children. And so when it's not necessary, can we mitigate that impact by doing something different? Also prioritizing the importance of families, making sure that children remain connected to their schools and communities, to really think about foster parents as supportive of the biological family, not just substitute parents. So a little bit of a reorientation there. Also focusing interventions on the well-being of all members of the family, and so use of relative care, for example, to again mitigate some of those early impacts. Building the capacity of communities to support children and families, thinking about things being place-based in order to maintain the consistency of all of a child's experiences with family, with school, with community, with peers. And then also working to develop and support a healthy and stable child welfare workforce, one that is led by capable and visionary leadership, and one that is otherwise knowledgeable and competent on the ground. And this is a very inclusive construct here, in that I would say everyone in this room, by virtue of your interest in being here, is part of that child welfare system workforce. That is not just speaking to our DFACS and its equivalents across other states. Family First has two general policy aims, so the changes here as a matter of the purpose of our funding and our laws are twofold. One is the prevention of unnecessary placements for children in care, as I mentioned, and that's where we'll be focusing most of our further conversation today. And then the other is around the promotion of family-based care. So you see then the connection to the restrictions on congregate care settings, where we have staffing arrangements rather than parents in the home. The prevention services opportunity, just to get right to it, is tied to particular eligibility categories of children and also particular eligibility categories for services. So under the Family First Prevention Services Act, states are able to draw down this Title IV-E, this entitlement funding, on a reimbursement basis for approved evidence-based prevention services offered to children who are identified as candidates for foster care, offered to pregnant and parenting or expectant youth in foster care, and offered to parents, both birth, adoptive, relative, or kin caregivers, and also non-relative guardians. So I know you heard from Dr. Toomey previously, and I'm sure others have reinforced this idea of both intervening with the parent or caregiver and also the child as a way to really thinking about strengthening that family unit. That very often, right, the relationships of parenting are that, they're dynamic. And so where we have deficiencies in parenting, we may have maladjusted children, and the ability to intervene with both of them is something that is critical to success. So then the first question becomes, those other two categories are a little more apparent, pregnant and parenting or expectant youth, and all the caregivers involved, parents or otherwise, of any category. The real question is this idea of candidate for foster care. And under the Family First Act, again, these prevention services can be given to, so federal money is available for the state to deliver prevention-based services to children who are at imminent risk of entering foster care, but for the provision of these categories of services that I've briefly mentioned. So a child is going to enter foster care unless we are able to give them the evidence-based mental health, substance use or treatment, and or parenting skills training to the parent or the child. And doing so, that kind of intervention early on is the prevention moment that would keep the child from entering foster care. Under the Family First Act, of course, there's a considerable amount of documentation and planning and other things that need to be in place in order that the state properly certify to the federal government the need for these services. So the DFACS will be working towards developing a prevention plan for each individual candidate for foster care that will indicate the strategy for the child remaining safely at home and which particular services will be provided. So you get generally the idea of a candidate as someone who's at risk of entering foster care. That is the opportunity for intervention in this prevention orientation to keep the child at home if possible. And we're going to do that with evidence-based or proven strategies for addressing the presenting problems. Additional opportunities around candidate is that funding is available and candidates can be defined to include those who have already been reunified or adopted or placed in a guardianship, and because of the fragility of that family arrangement, the child may re-enter care. So we can also use these prevention services not just at that first allegation or first report or first exposure to the system, but also to prevent the child's re-entry into the foster care system or child welfare system. And those services can be provided for up to 12 months, so that's the episode of candidacy. But under the federal law, the state can essentially recertify or redesignate the child as a candidate and for an additional 12-month session of services. And that links those candidacy episodes, there can be multiple candidacy episodes. So you can be serving children and families in this prevention paradigm through this mechanism really sort of unendingly, except for the awareness and the judgment that at some point something else may need to be required. I know you're going to hear more about the Title IV prevention services, but just to give you a sense of how this is structured under the federal law, the idea of evidence-based services are really those that have been rigorously evaluated to be proven, to be demonstrated and shown to be proven for correcting the particular thing or addressing the particular target population or cohort that they're being administered to. So that's the idea of evidence-based. They get more and less aggressive, all the way up to sort of randomized control trials. And there are several clearinghouses that are kind of the go-tos for determining which services out there by which name have gone through this experimental or quasi-experimental kind of evaluation so that we know they work. Under the Federal Family First Prevention Services Act, the Children's Bureau, which is responsible for overseeing all state child welfare programs, is going through an additional process of systemic review. So they're going to look at services that are out there. They're also accepting nominations or requests by states to evaluate particular services that may be available in a community or within a state or are thought to be effective. And they're putting them through their own process of review. And then they're assigning them to one of 3 tiers of rating, whether it's promising, supported, or well supported, that being from sort of less rigorous to more rigorous in terms of the evaluation and the determination of effectiveness for addressing a particular target population or presenting problem. The Family First Act requires that states spend 50% of their money towards well-supported, that top rung, that sort of brass ring designation of evidence-based. And again, I've mentioned the 3 categories. And then there are also evaluation, fidelity monitoring, outcome reporting requirements attached to all of this. So this is one way to give you some grounding in sort of the apparatus and how the federal government has set this up, but also as an indication of just how much ramp up is going to be required within Georgia and frankly all states in order to build this kind of capacity and set in place these kinds of fidelity monitoring and quality review and the kinds of things that need to happen both at an individual case level and systemic level in order to comply with the federal framework such that we can then draw down our portion of federal funding for that. There has been a first round of systemic review conducted by the Children's Bureau pursuant to the process they set up. And so I have here for you a quick summary of where we are in case you're looking for particular programs or services with which you might be familiar. You can see where they are in this scheme. So in the in-home parenting category, you see there are ones that have been currently rated, these meaning these are the ones that the federal government has given a thumbs up to states, that these are ones that are approved and can be used in this prevention services paradigm and will be then reimbursed by the federal government according to the framework. So those include Nurse Family Partnership as well supported, Healthy Families America, Parents as Teachers. I know you've gotten some information and have greater or less familiarity with those. And then you can see on the right side a series, this is going to be an ongoing process that the federal government undertakes with respect to receiving requests and otherwise identifying services and putting them through the systemic review process. So you have then on the right side a series that are currently under review and soon will make their way to one of those tiers or be determined not to qualify. Same approach here on the substance abuse prevention and treatment side. Currently rated multi-systemic therapy, methadone maintenance therapies, and families facing the future, and another half a dozen or so under review. And then on the mental health side, parent-child interaction therapy, trauma-focused cognitive behavioral therapy, multi-systemic therapy, and functional family therapy, and again, a little more than a half a dozen there under review presently. And there has just been another round then of solicitations from states. So again, this will be an ongoing building of a catalog of options, which really at the end of the day, once they're in the currently rated side of my slides here, that really is the menu again of services available to states, where states can feel confident that they can choose from that menu and be reimbursed by the federal government pursuant to this opportunity. The additional opportunity, I'm not sure how much information you've received about how Title IV works. It's a pretty complex financing scheme that has some really big restrictions on it that are the reason why it's only Georgia's 3rd largest funding stream. that income eligibility requirement that sort of holds us back on the foster care side from getting more federal participation, federal funding for foster care, is not a part of the eligibility criteria for prevention services. So in theory, in fact, I think predictably in reality, we will be able to serve more children, more families through this prevention services opportunity than the way that we look at the financing on the foster care side, where this is more constrained or restricted. The state has to submit a prevention services and programs 5-year plan. That will be where you will see our state's decisions, choices, selections from among that menu of approved services in terms of what Georgia DFACS decides to use our state dollars to pay for in the matching environment and then seek federal reimbursement for. So to put it another way, I don't think there's any reason to expect that all states will sort of select all of the possible range of services and programs from that menu that the Children's Bureau sets up and those tiers of evidence-based services, but instead will be more selective about what services we choose in order to meet the needs of our particular population. So who are the children who are putting particular pressures on our child welfare and foster care system who could, based on this framework, be served in a different way, and we will choose services accordingly. So I can give you an example. For example, we know we have a lot of teenagers where parents, their children's behavior may be particularly problematic and parents just give up. And that might be an opportunity under the right circumstances for intervention through these prevention services to give that parent some in-home parent skills, competency-based training, and also perhaps address what might be a mental health challenge for that child, right? Instead of receiving that child into the foster care system. So that's one example. And so we would look for the kinds of evidence-based services that allow us to address teenagers with those kinds of presenting challenges, for example. So I can talk a little bit more about that as we have the time. Tom Rawlings, director of our Division of Family and Children's Services, has presented his vision for how we might use the Family First Prevention Services Act to leverage bigger system goals. Those include, of course, safely preventing removals to foster care through the use of these effective prevention services, supporting models of extended family preservation that allow children to remain connected to their families, to their communities, to schools, to peer groups, to familiar surroundings, etc., to making sure children are appropriately placed in settings that has more to do with the piece that we're less focused on today, and then leveraging and investing in communities to make sure we build the kind of capacity within local communities that allows us to serve children and families where they are instead of displacing them somewhere else. For your information, based on appropriations that all of you are responsible for, last year, the Division of Family and Children's Services was able to hire some dedicated staff or create positions for dedicated staff to really lead these efforts around the Family First work. Shelby Zimmer is, I've got her title there, that's her old title actually, Federal Plans Manager. She is the Family First Prevention Services Director, and she also now has a program manager. So there are specific points of contact for you, for the public, for stakeholders as this planning goes forward. And through some additional assistance, there has been launched a website. So there is an intentional strategy around communicating both internally and externally. So I can direct you to the blueprintfamilyfirst.org site for ongoing updates. You can subscribe to newsletters and things like that to get additional information. But generally speaking, for the past year, the state has been really undertaking some system assessment. So you're sort of taking stock of the status quo of our practice and policy and laws and outcomes in order to then know how we might change things going forward. And so now we're really, as this winter settles in, really moving into that next phase of things that will be more visible, more forward-looking with respect to Family First implementation. And the key here is around the definition of candidacy. So as I see it, for your focus around young children, this opportunity around candidacy is really the highest leverage. And that ties in really nicely, the timing happens to be really nice, that the state has convened a multidisciplinary, multi-sector work group to meet actually on December 3rd to start the work of looking at the data, the context around this decision, to bring in, and that again involves other agencies, so also the kinds of considerations you all have also entertained here about where agencies intersect or can align in making sure we understand who is our at-risk population, what services do we have already, and where can we purchase additional services to better serve that vulnerable community. There are only a handful of states at this point that have submitted their prevention plans to the federal government. So we have a very small sample of how other states have defined candidacy, or how we've determined who the cohort of children are, the population of children who are at imminent risk of entering our foster care system. And really, states have gone about it in one of two ways. One is to use a risk assessment instrument, much like what we see on the juvenile justice side, where you understand the needs of a child, their opportunity for being in the community versus something more institutional. You can draw those analogies across the systems. The other is to really define candidacy with respect to certain characteristics of the child or the case. So what was the nature of allegations? What do we know about what the child's needs are? And determining candidacy in that way, or some combination of both. So you have Utah's here as the example of looking at case or child characteristics. They're going to say that the kids who are most at risk of entering foster care in Utah, and therefore for whom the state will provide this prevention services opportunity, are those who, where there's an indication of substance use or addiction, mental illness, lack of parenting skills, limited parenting capacity. Parents may need additional support based on the severity of needs of the child related to behavior, developmental delays, physical or intellectual disability, or these adoption or guardianship arrangements that might need some additional aftercare support or risk dissolving or disrupting. So that's one example of how we could approach this. Nebraska sort of sets out another example, which is really to look at, again, these kind of case characteristics, but they also apply a risk-based model. They use structured decision-making to sort of assess, which is a tool, to assess and assign a particular level of risk that the child might enter foster care. So you see kind of the combination of both. Which gets us to, I think, what you're most interested in. Thanks for indulging the long lead up in terms of what we see as opportunities for Georgia. So again, to the question of which children are imminent risk of entering our foster care system, and how can we serve them in this new prevention services opportunity. So I also, sorry, apologize for the typo. But these are really just for discussion only, in that I don't want to set any expectation that the state has committed to this or that I have the authority to speak on behalf of the division. I am closely involved in the work and the planning around this, and so I do think these are reasoned judgments, but we haven't made those decisions yet. So certainly we could think about those kids at imminent risk of entering foster care as being those who are expectant parents, much like the Act specifically identifies. Those are real opportunities to strengthen families, young families, and minor parents and their children, and not use foster care as the response for that circumstance. Also looking at short stayers, and by that it's sort of our sort of casual way of talking about the children who enter our foster care system and are reunified within 72 hours, maybe up to 30 days. You can put that marker at a different place, but the idea is if we have such a quick turnaround, it invites the question of, did we need to remove that child into foster care to begin with? Certainly children living with relatives need, as you all are well aware, need a lot of support in order to strengthen and sustain that family arrangement. Children who are siblings of children who are already in foster care are at great risk of entering foster care, right? So once we have a child, in Georgia we remove children in an individual basis, so you won't necessarily see removals of entire sibling groups, but the indicated child, the child who has been harmed. But of course, then you expect that there's conditions within that home that put the other children at risk as well. As I mentioned, certain case type allegations, there have been a lot of requests and discussion around this, looking at, for example, prenatal abuse cases, where substance use or addiction is present, mental illness, as I mentioned. We have these categories around parental inability to cope, which is a reason that children are removed and brought into foster care, and relatedly, child behavior. And so those are areas for deeper investigation to determine how we might serve those children better and without as much investment and intrusion. Aftercare, I've mentioned that before. And then also looking at youth involved in the juvenile justice system, this being a correlate to the child behavior issues, and where we might also tap into the evidence-based services and community capacity that has been generated through your good work on juvenile justice reform over the last 5 or so years. I just want to, and you can yank me, I didn't pay attention to when we exactly started, so don't let me go on too long. But I did want to present to you some look at the data that we have to help inform these decisions. So these are not arbitrary decisions. We are looking at system patterns and trends and how children enter and use our system so that we can understand then how to recalibrate it and take best advantage of this new opportunity. So this first slide, and I know that this is far too small for you to read. It's actually too small for me to read up here. But this represents, so this is all 159 counties. The ones that are in shaded gray there are really just pointing out those counties where we have more than 10,000 children in the population. And the horizontal line there shows you the statewide average of removals per 10,000 children in the population. So on the whole, we, on average across the state, I'm going to have to look at my notes to make sure I get this to you. Statewide average is just over 2 children removed per month. So it's statewide average, right? Doesn't account for differences across specific counties. But what we do know is and we can see that, obviously we can look county by county and we have that information. But we also know that true today, historically true, really as a stable characteristic of our child welfare system, about half of the kids who are in our foster care system are removed for reasons of neglect. Now, neglect is a broad and vague term. It involves everything from inadequate supervision, right? You didn't have a child care option in the home, for example, or all the way to something that's much more chronic and deprives children of their basic necessities around food and clothing and shelter. So that's something worth noting, but we also know that poverty also plays a significant role in neglect. And so again, here, these might be opportunities in thinking about where neglect factors into our child welfare system to differentiate and, again, recalibrate our system response. Those reasons for removal get really complicated as a data matter because of different practices in terms of coding by caseworkers, and you can choose more than one reason, but you don't have to, and so we don't really have as precise of a look as we want. But I can tell you that another 44% of children in our foster care system are there because the worker indicated that there was a presence of caregiver alcohol or drug use in the home. So there is a clear opportunity identified by the Family First Act for a different kind of intervention. And again, based on severity, which is why we want to look at both case characteristics and risk, right? So a parent's use of a particular substance is, presents as opposed to a different kind of substance would change the risk in the home. And so those are the kinds of things that we are looking at as we go forward. Just a quick look. This is the percentage of children discharged within 1 month of removal. So these are what we would refer to as our short stayers. Those kids who come into our system and then are returned home within, for this chart, 30 days, which may be necessary, but that also is an indication, again, of a high use of our resources at the state level, a deep intrusion into the family, and it's something that may be able to be addressed in a different way. As a matter of statewide average, about 10 and a half, right, you know how this goes, children are discharged within 30 days of removal every month. So, and I can tell you that goes from, in Warren County, which is, I figure you might want to know that big one over there on the left, that's Warren County. But again, put into the context of Warren County that received 64 maltreatment reports in this time span, they removed 4 children, right? So they removed all of the children they got, but they also returned those 4 children back within a month. So you see those kinds of dynamics. The county size matters, the volume of child welfare work matters. We see rates in our larger counties. So Fulton, about a quarter of children are reunified within 30 days that are removed. So that's a much higher number, as you might expect. Clayton's right up there too. Gwinnett's about 19%. DeKalb is around 9%. So, and about 60 of our counties aren't showing up here. That's the bottom line there, where if they're going to remove children, the children stay in care longer than that. So this isn't meant to be, you can't take any one of these data points without all the context that attaches to it. But just to give you a sense of looking at these opportunities for greater stabilization in our system. This is the re-entries to foster care as a percentage of removals. So when children leave our foster care system, do they come back? That's a real indication that we didn't do what we needed to do to strengthen that family, right? The idea of re-traumatizing a child because of another incident of abuse or neglect, another removal, and this kind of pattern is particularly problematic. And so keeping an eye on these re-entries, the statewide average right now is 16.2. Pike County has about a 67% re-entry rate. That's really high. Pike, Montgomery and Jeff Davis are close to that. At about 50% of their kids re-enter. But again, those counties, the resource issue is one that we need to look at there, the sort of resource capacity and competency in those communities. Our larger counties, Fulton is about 20%, DeKalb 16%, Cobb 13%. So we do have a high reentry issue in Georgia, something that's worth paying attention to. The theories around this are many, including the ability to offer the right services. And so in this new opportunity, we can think about evidence-based services as being known to be more effective at addressing that underlying problem if we assess it correctly. The other issues are, at this point, we have only foster care, really. We have a couple of other interventions, but foster care is the one that we have the most robust financing for, which kind of creates its own kind of incentive. We have one tool effectively. And so when that tool is not deployed correctly based on what the families need, then we see that it doesn't work and kids go back home and we haven't really addressed the problem. So in some ways it may actually be a proof point of what the policy change is that is promised by the Family First Act. Lastly, before I turn to questions that you might have, I just wanted to remind you of legislation that was passed last year, House Bill 472. This is a complement to the work around Family First. I should mention we did some codification as a compliance bill in Senate Bill 225 to make sure that our statutes were set up to demonstrate state compliance with the Family First Act requirements. But all of that work is really that deeper end work around the placement continuum. House Bill, so it doesn't speak to the prevention services piece. House Bill 472 is the front end opportunity that really is a state innovation here in terms of our legal response. And what it does is extend the court's authority in the protective order context to provide for what's been referred to as temporary alternatives to foster care that would allow court oversight over some of these opportunities that or these strategies that DFACs might take to keep children in the home. And by doing so, give DFACs a little more support, make sure the family feels more secure about what's required because they'll have a court order that sets forth all of those terms and conditions, and allows for, of course, all of the rights of all the parties to still be respected. So this is a little bit outside of the primary focus of Family First, but is a great opportunity that we seized to already anticipate the next step and look forward to the engagement of the courts in this front end work that is only going to become more robust under Family First. So I know that was dense and fast, but I'm happy to entertain any questions that you have.
Representative Oliver.
Thank you very much.
Sure.
I'd like to go back to the programs that have been vetted by Children's Bureau,
Yeah.
specifically Nurse Family Partnership and Healthy Families. I know those two programs existed historically in Georgia. They're national programs, not Georgia programs. Do they exist today?
In limited capacities. So we do not have across the state the array of evidence-based programs, period. What we do have is probably more robust now on the side of interventions for kids who might be exposed to the juvenile justice system, but we do have some remnants of some of those early programs that you mentioned. So there's a start and a history that we'll try to leverage.
The Nurse Family Partnership existed in Macon for a very short period of time. Very, very successful, very limited. What is the overlap for this money with public health money and Medicaid money?
It's a great question. So I'm going to go back to some of those slides just so you have them in front of you. So yes, the ideal here, if we can pull it off, is to have something that feels like certainly more alignment. I'll go so far as to say, because I'm not a state person who's responsible for implementing, really thinking about braided or integrated funding here. As you know, there are a number of services that are provided by all of our state agencies, often through Medicaid for this particular population, and we have strong silos built around them. So the opportunity here, the effort at this point is to have these cross-agency conversations, both by top-level leadership, so the commissioners are certainly all aware of this and are starting to have conversations that are really at that level of integration, and then certainly throughout the entire field level so that we get the practice pieces too. The opportunities, I can tell you specifically the one example of that, which I think is something we should all be really proud and supportive of. through the IDT that meets, the interdisciplinary team that meets, and the Behavioral Health Coordinating Council kind of structure. In October, the Prevention Services Clearinghouse, this is the Children's Bureau solicitation for programs that they will put through the systemic review. They sent out another public call for programs, and our IDT got together, so that's DFACS, DBHDD, the Center for Excellence for Children's Behavioral Health, and the Health Policy Center at Georgia, to submit a state response. And in that state response, they pooled together the sort of services that they had available collectively and wanted to have the Children's Bureau look through to determine whether any of them are going to be approved for this. And there were about 20 different services that they submitted. So this is not the list of services Georgia will fund, but looking for the Children's Bureau's attention to tell us what we already have falls within the criteria that they're looking for. So I've got a list of about 20 different services there as well.
The Nurse Family Practice Act came out with managed through public health.
Yes.
So, I mean, that's where my mind is going, that different agencies managing different programs.
Yes, that's true. And you know, we have historically have some challenges. It's just with the agency coordination, so nothing about intent or good faith effort, but around, for example, using Babies Can't Wait, which is what we already have in the public health context, to serve children who are in the child welfare context. And that's kind of an obvious fit too. That's sort of different than what we're talking about here, but we have historic challenges in breaking down those silos. So that will take a lot of good and creative thinking and a lot of effort. And a lot of transparency, I think, too, between the agencies.
I don't see any other questions right now for you. You got one? You got one? Okay. 22.
Thank you. Appreciate it. A lot of information.
I know.
It is, and I'm pretty ill-equipped to ask some questions. You answered a lot of my questions through the thing. But I want to go back when you talk about removal, necessary and non-necessary.
Mm-hmm.
You kind of did that, and kind of, are you trying to change the definition or change when we remove children and when we don't? Or is it pretty rigid?
Question. I think that's a really fair question. So no, I think what this Family First Prevention Services Act and Georgia's efforts to comply with it are about expanding or extending the state's responsibility. So the state still has a responsibility to intervene when a child is harmed or at imminent risk of being harmed. The question is, what do we do once we intervene, once the state uses its authority to intervene on the privacy of the family? Currently, most of the funding that's available means that we have one I don't want to oversimplify, there are a couple of other options, but really one big, robust option, and that is removal and placement in foster care. And what we know in Georgia and nationally is that we don't get great outcomes when we only have one tool. So for some children, they'll need to be in the state's protective custody, be taken out of their homes and placed somewhere else where they can be served by the state and protected by the state. Other children, though, there are a whole lot of reasons, of course, children come into foster care. And so Family First is sort of looking at, there are a lot of reasons children enter foster care for which foster care is not the best solution. And so when we think about parents who have mental illness, that's going to be a chronic condition, right, that needs responded to and treated. Taking the child out of that home, doing that trauma to that child, and foster care itself doesn't fix any of that. And so there are different opportunities now that there's a greater evidence base for services that we know better how to in a more subtle, maybe morally appropriate, maybe hopefully more effective, more fiscally responsible way intervene when that's the circumstance, so that we don't have to use foster care, because foster care doesn't work for those circumstances and we're overpaying and don't get good outcomes. So the analogies are very similar to what you see when we talk about criminal justice reform and juvenile justice reform. When we use these deep end interventions by the state, the ones that are most restrictive, the ones that are about state custody, if we don't triage the need for that then we get too many kids in and we don't do well by any of them.
Exactly.
Or too many, same thing in foster. Those analogies hold. It's a different orientation for state intervention, of course, in the child welfare context, but foster care, in my analogy, is the equivalent of when we put kids in prison, for purposes of thinking about the intrusiveness and the restrictiveness of the state intervention. So the idea here is just like in juvenile justice and adult criminal justice, where we understand now through a building body of evidence that we can get better results that are more fiscally responsible by doing things that are in the community that allow people to stay connected to their communities, to treat the underlying root causes for their problematic behavior. It's the same thing really that we're reorienting to here on the child welfare side, if that helps to think about it that way.
Oh, yes, thank
Good.
you.
You're welcome.
I appreciate that.
Yeah.
Very good.
Okay. Now I don't see any other
Great.
questions. Thank you. That was very informative,
Appreciate
and you really, in a very short amount of time, dealt with some of the many challenges we have found in this conversation, particularly in the transparency and coordination of services and how we are called. We must do this. It's really not an option anymore from the federal perspective in many places, but this Families First is going to offer us a great opportunity to really rise to the occasion and look out for Georgia's children with the use of fidelity, one of my favorite words. So
Yeah,
thank you
I think
so
it does.
very much.
Again,
I
thank you for the
appreciate it.
opportunity and for your patience as we did pack a lot in a short amount of time. So happy to help the committee in any way that I can, and thank you for your good work.
Thank you, and we may very well be back in touch with you to find out some more
know where to
questions
find
as
me.
we put together our proposals and suggestions. I think we're going to put together a very strong report.
Great, I'm sure you
So,
will.
thank
So
you.
again, thank you so much.
Thank you. All right, so now a very personal treat, I think, is ahead for each of us here as we listen today. Someone from Rome, from my hometown, Dr. Susie Henderson, the principal at Alto Park Elementary School, which is part of our Floyd County system of schools, who has a true heart for this, but has just returned from a strong conference, I believe, from representatives across our nation. I look forward to hearing more about what you've learned recently and what your time, not only in the classroom, but serving as a principal, has brought forward. So, Dr. Henderson.
Thank you. I'm going to pull my presentation up really quickly. I have just a few slides. Is that in a good spot? Okay. First, let me begin by expressing my deepest gratitude in having the opportunity to come and speak with all of you this morning. As Representative Dempsey said, this is a subject that is near and dear to my heart. This is my 23rd year in education. I began as a speech pathologist. Then I was an assistant principal, and this is my second year as a principal at Alto Park Elementary. I would also like to say that I've not done this journey alone. When I came to Alto Park in the spring of 2017, I met a wonderful teacher there who I quickly discovered shares the same passion that I do when it comes to learning about the brain and being trauma informed. And she was able to attend the conference with me in Denver, Colorado. Her name is Stephanie Ayers. I had hoped that she would be able to come present with me, but she is on vacation with her family. So, as Representative Dempsey said, I had the amazing opportunity to attend a trauma-informed conference in Denver, Colorado, November 11th through the 13th. And this conference brought together many experts on trauma, and a lot of the information that has been presented here, I know the first meeting, I did attend the first meeting, and so a lot of the information that was presented is what we learned at our conference. So at this conference, it brought together Dr. Bruce Perry, who wrote the book, The Boy Who Was Raised as a Dog. That book chronicles several children who have experienced severe trauma growing up. He has worked with them, and he discusses really what happens in their brain when they experience that trauma. Also, Dr. Ross Green was there. He is known for the book Lost at School, and this is a way to work. His approach is to work with kids with behavioral challenges and really to have conversations and work collaboratively with the student, with the teachers, with the parents to come up with a plan for how to address those behavior challenges. Also there was Heather Forbes, who is actually the co-founder of the Beyond Consequences Institute. She wrote a book called Help for Billy, and Billy is just kind of a synonym for any child who is in school and is experiencing trauma. She also co-wrote the Trauma Informed School, which is a step-by-step approach for administrators and school personnel when they are trying to transform their school into a trauma-informed environment. Perhaps my favorite speaker there was Jim Sporleder, and he also wrote the Trauma Informed School. And what's unique about Jim is that he wrote this book from personal experience. He is the former principal at Lincoln Alternative High School in Walla Walla, Washington. And under his leadership, Lincoln High School went from being a traditional discipline type school to a very much trauma focused, this is how we're going to look at our students school. And his school gained national attention because they had a dramatic drop in out of school suspensions. They had an increased graduation rates, and the number of students going on to post-secondary school also increased. And while this is a high school that he works at, it's as I listened to him speak, I couldn't help but wonder, what do we need to do in elementary school or even at younger ages before they get to high school? So what made his session so powerful and different from, Dr. Bruce Perry is full of information, and he has worked with so many students and is an expert on trauma and what happens in the brain. And Dr. Ross Green is an expert on, okay, this is how we take this information, and then this is how we help the kids. But Jim Sporleder actually lived this every single day for several years as he worked as a principal here. And his journey caught the attention of a man named Jamie Redford, who spent a year filming the documentary Paper Tigers. I don't know if y'all have heard of that, but we were able to watch that on Tuesday night at the conference, and it was truly eye-opening, and I was going to show just a little clip of it, just the trailer here.
You're not broadcasting there yet.
I'm not there yet. Sorry. While we're waiting on that, this was a documentary that every educator really needs to watch. And again, while it's based in a high school, as we were watching this and as I was able to speak to Jim afterwards, I asked him that question, what would happen if we could intervene with these students at the earliest age possible? And not just the students, because a lot of what's shown there is where he's also working with the parents and the families. That's okay. Yeah. Is it okay if I can keep talking while she's pulling that up? Okay, so after we watched Paper Tigers, it was actually Monday night when we watched Paper Tigers, and then Tuesday was the last day of the conference, and his session was the last one that we attended. And after his session, I spent some time talking to him and really sharing with him the need in Georgia, of course, because this is the focus here, but really speaking about Floyd County and Alto Park Elementary in particular to become a trauma-informed school, and kind of shared with him some of the things that I have done to help us get there. And he was so gracious and listened as long as I wanted to talk. He offered some suggestions. And so as a staff, we have a planning day on January 6th, which is when we come back from Christmas vacation, and we're going to watch Paper Tigers. And then on January 9th, he is going to do a Google Hangout with my staff so that they can, really get the ins and outs of what he did to transform his school.
We're going to put a quick call into IT, so just keep talking and maybe
Okay.
we'll close with that.
one of the biggest, I guess the purpose of this conference is to equip educators. So at the conference itself, you had administrators, you had counselors, licensed clinical social workers, psychiatrists, and teachers were there, because that was the whole purpose. And I know as I've watched, tried to catch up on some of the sessions, one of the themes that I keep hearing over and over is how we need to create a workforce, how we need to really build up our workforce of the students who work with of the people who work with our students. And yes, early intervention, 0 to 5, is the best time to intervene. We have such a small window of time with the kids, and their brains, the younger they are, the more neuroplastic their brains are. But there are so many kids in our school now who, without serious intervention, will not reach their full potential. And that's our job as educators. One of the first things I heard Dr. Veda Johnson, she said it that, every child is born with the potential to change the world. And of course, she said it was her job as a pediatrician to make sure that happens, but I feel it's our job as educators to make sure that happens. So as we're going in and we're trying to support the parents, we really have to have a focus on supporting the teachers as well. Our students must have that connection and attachment. If they do not have that connection and attachment, then they don't learn. And often our students are very transient. They're moving in and out. We do have a high poverty rate in Floyd County and especially in Alto Park. So those are things that we have to concentrate on. The biggest takeaway, one of the biggest takeaways from this conference is this has to be who we are and not what we do. Trauma-informed education is not something that I want to pile on a teacher's plate. As an administrator, it just seems like every year, and this being my 23rd year in education, every year it seems like we're piling one more thing and one more thing and one more thing on teachers' plates. And I don't want to approach my staff and tell them, hey, this is just one more thing that I'm going to pile on your plate. Trauma-informed education is a journey. It's not a checklist. It really has to be about who we are. And it's also not, because some will take the idea that, well, we just want to let kids do whatever they want. And that's not the idea either. It's not about kids doing whatever they want. It's really setting a boundary. It's making kids feel safe and supporting them as they take this journey. So the success that was experienced at Lincoln was because the teachers were trained. And there was a step-by-step, very focused, very intentional approach on how it was done in that school. Every person in that building, from the janitor to the front office staff to the custodian to the teachers to the counselor, everyone saw the students everyone saw the trauma-informed and became trauma-informed. Jim shared during his presentation that this is very much a mind shift. And it has to be me understanding the power of one and the impact that I can have. That I, as the adult, have to become the one caring adult in my students' lives. And so I, as the administrator, am working to equip my teachers to help them become that. And to know that we have the opportunity to change the life map for a child. And I applaud the work that you all are doing, because I really feel like we're on the way. We are making progress in doing that. But once we understand that we all, everyone doing this work, that we have that potential, then it becomes who I am as a person. And it just, because that's my mind shift. That's how I think. It becomes who I am as a person. And then you can hand me a tool to use, because then I'll know how to use that tool correctly. Then we become that as a staff. And then once we become that as a staff, then it creates the culture that we have and our identity, and that's who we become known as. And you just become this whole environment where the students feel supported, they feel heard, the teachers feel supported and feel heard, and the parents feel supported and feel heard, because often they don't, and they stay away from school because of that. So again, this cannot be another program that I take to the teachers, because we have piled so much on their plates already. and the emotional burden that many of our teachers carry, because we actually, we see the kids every single day, and, we see them being taken into foster care. Often we're the ones who have to make that report to have that happen. So this emotional burden that our teachers are carrying because of our students is astronomical and is absolutely wearing them down. The emotional labor is a lot. So it is with this that I say we have to prepare them, and we have to start doing things differently. Ross Green said that, what we did a long time ago was inclusion, where we have every child in the classroom during that time. And we put kids who had traditionally been placed in a different environment, and we do not need to go backwards and go to that kind of model, but they had been placed, in a different environment, and now they're in general ed classrooms all day, every day, which is where they belong. And that's a fantastic idea, and I support that totally. But we have to do this under one condition, and this is what he said, is that you prepare the classroom teacher for what's coming. That the classroom teacher has to be prepared for that, and regrettably, a lot of that has been left out. He also said what's hard is the amount of support and training the teachers need to be able to keep their heads above water, given that oftentimes their classrooms are stacked against them. One of the speakers at the conference said, if you really think about it, 32 students to one teacher, that is an impoverished emotional environment, because that one teacher, is trying to meet 32 needs of varying levels in her classroom. And so teachers don't receive the training they need to really understand how to work with behavior issues, and that is putting them in a really difficult position. And so, again, these are all ideas that came from the conference. Jim also said that, we expect our students to focus at school after they have been abused the night before. And so in his school, he said, we developed and implemented a trauma-informed model at Lincoln, and despite it being our first try and not being perfect, it worked. And see, his whole idea he attended a training with John Medina, who's written a lot of books about the brain, on trauma and the impact on the brain. And it so resonated with him that instantly he went back to his school and began the work of becoming a trauma-informed school. And he said that it worked. They had an increase in attendance. We had students making up credits in areas where they were deficient. And the bottom line was that as they addressed the social emotional needs of the students, and once the relationships were built, because again, we have to have that connection, the data came naturally. And he said, I believe that it all happened because what our students found, and they found hope. And it was a hope and resilience that re-engaged our students back into the learning environment, that it was all about the hope, and the hope was huge. And our students need that hope. Our teachers need that hope. And the hope was the catalyst. And once they reestablished that hope, then the data came naturally. We in education are definitely data-driven, and we like to see the numbers. We like to see our attendance going up and our test scores going up. But we would like to see our graduation rates increase. We like to see our kids staying in school. But in order to do all of that, we have to take a step back and look at, are we coming about this the right way? And that's where he discovered that once they met the social emotional needs of their students, then all of that just came naturally. That they didn't have to keep working at it or increase more academic time or, things like that. They had to focus on the social and emotional piece. And he said it really was about creating a balance between all of it. And as a nation, we are data-driven in our policies. And if we're going to get our academic scores where they need to be, we have to focus on the social and emotional piece. So I want to bring this a little bit closer to home. Can I think it'll work? Okay. I am the principal at Alto Park Elementary School, which is in Floyd County. Floyd County has just under 10,000 students. But at Alto Park, we are a pre-K through 5th school. We have 454 students. There are 2 administrators, 1 counselor, 20 classroom teachers, 3 special education resource teachers, and 2 special ed parapros that push into the regular classroom. We have 4 self-contained special education teachers and 8 special ed parapros. We have 1.5 speech pathologists, and we have 2 ESOL teachers. So that's the support that we have for 454 students. This year alone, we have had 3 students who have been hospitalized for making suicide ideations. 1 student has been hospitalized 2 times this year already, and it's just November. We have met with parents, and for the most part, the parents just don't even, they're just at a loss as to help their child as to what to do. And most of our students spend more time with us than they do at home. We have several pre-K students this year, 4-year-olds, who are also struggling behaviorally. And their behavior is disrupting the learning environment for the other 21 students in that classroom. And at times it's causing an unsafe environment. Toys are thrown, and it's just that the students are having a hard time staying regulated. So right now they are often removed from the classroom. And I do not believe that that's the answer, that they need to be removed. But what is needed is support and a shift from reacting and telling to asking and responding, and that's not easy. Especially when you have a 4-year-old or a 10-year-old who is throwing things at you or yelling obscenities at you. So we are in the very beginning stages of becoming a trauma-informed school. You always start small. But just as we came back from the conference, Stephanie Ayers, who is the teacher, she's actually one of our interventionists, she went with me. And when she came back, she immediately put into practice what she had learned in the conference. And so she sent an email to our entire staff of an incident that happened with the student. She said, "I just wanted to share a quick summary of an interaction I had with the student today. I noticed this student was having a difficult time getting started on an assignment, so I approached her and mentioned what I noticed. The student responded yes and responded that she was going through a tough time, so I took a few minutes to listen to the student. The student was fearful of being left alone with her mother when her mother has to go to the hospital to have a baby in just a few weeks. The dad is incarcerated and most likely won't be home when the baby is born. She described in detail her situation at home. She also deals with students being very unkind to her. I let her talk for a few minutes until I thought she truly felt heard. The conversation led to me sharing my news of expecting a new grandbaby and a quick discussion of the joys of holding a sweet little baby. She lit up at the thought of holding her new baby brother. With just a little help, she was able to get that off her chest and shift her thinking to something positive. Then she immediately looked down at her work and began working without a single prompt. She went from being completely dysregulated to a regulated state and able to focus on her work. I share this because it was so powerful to see how effective it was to give this child a voice at that moment when she needed it the most. Her brain was stuck in a place that needed love and trust before she could think and reason about anything academic. I could have very easily just redirected her or given her a warning or consequence for wasting half of the class period. I'm so glad at that moment I responded differently. I can't say that I always respond with empathy when I should, but today I was thankful that I did. Hoping this encourages you as you work to build relationships with your students. So grateful for the work we do as a team. So that email was sent to the entire staff, and because that email was sent out, there's a book called Because Brian Hugged His Mother, and it chronicles Brian hugged his mother, and because Brian hugged his mother, she was happy and she did something else, and that person was happy and so they did something else. So then I had another teacher, a first grade teacher, who sent a response. She said, "I had a similar situation with a child today. He came in completely off. He refused to read and participate during reading small groups, so I allowed him to sit and watch. We talked after interventions about attitudes, and it was his choice to have a good one or a bad one. He chose good, and he threw his bad one in the trash. As the morning progressed, he did fairly well, but then began to shut down mid-morning. I sent the whole class to the carpet and had a discussion with him in the back of the room. At this point, he was weeping with tears, and so I had him explain to me what was going on. I asked him if something had gone on at home that morning that made him upset. He sat and talked with me for about 5 minutes and told me everything that had gone on at home and how it had bothered him. After I was able to talk through this with him, and tell him how much I loved him and was there for him, as well as express to him that he was safe at school, he was able to calm down and breathe. He then did every bit of his work and did it well. Taking the time to really listen to your kids and give them a voice does work. My group of kids this year deal with so much before entering my class that I spend a lot of time showing them what real love with discipline is, as well as proving to them that I am a constant in their lives. He needed love and someone to listen to more than he needed reading today. And so as you know, when we talk about developing a ready workforce, I can't think of a workforce that needs to be developed more than our teachers. I can't think of a better way to use funds than to ready the teachers and other educators who work with our students every single day. And the best time and place, as we have seen, you know, as research shows, the best time and place to teach students to regulate is in a natural environment. And, you know, and they are at school. That school is a natural environment for them. And when we begin to lay on academic expectations on top of the social and emotional challenges that they have, then they quickly struggle and they become dysregulated because they're at a point where their brain is like, I'm not safe. And so everything else starts to shut down, and you never make it to the front part of their brain because you don't get out of the brain stem. And then often what happens, unfortunately, is when you have a dysregulated student, then you end up with a dysregulated adult, and a dysregulated adult cannot regulate a dysregulated student. So Stephanie and I have been working to bring awareness at our school this year. All of our teachers have some familiarity with ACEs. We have provided them that training on adverse childhood experiences. We have talked about what happens in the brain when our students have experienced trauma, the impact that it has, and I truly believe that awareness is the first step. And I am so thankful for this committee in creating this awareness. Representative Dempsey, I'm just humbled and honored that you are doing this work because awareness is the first step. But we can't stop there. We need resources. We need human resources. I believe it was in session 4 that Dr. Cholano talked about the training that she does with parents where they sit and they're in a training room and she kind of whispers to them. So like they have a walkie-talkie and she kind of tells them, the parent in the moment, what to do. And, you know, I think we need teacher whisperers. I think we need people who can come alongside and watch what's happening in the classroom and offer the teachers that support. Someone who can tell them in the moment, hey, why don't you try this? Why don't you just take a step back? Why don't you just give the child some space? Those type things. And it's going to take repetition, and a lot of consistency. And I don't know what the exact cost of that type of training would be. I don't know what that would entail or what it would look like. But I know the cost of inaction is more than we can continue to afford to pay. Officer Chris Fincher, who is a Floyd County police officer in Floyd County, presented at our principals meeting last week, and he did talk about, you know, the drug concerns in Floyd County. He did address the mental health, and so even our Floyd County police officers are working together to do this. And so I asked him afterwards, how much does it cost for someone to be in jail in Floyd County? And he said it costs $80 a day for someone to be incarcerated. He said it costs about $5,000 for 2 days in the hospital for someone with a mental illness. And the average stay is 11 to 15 days. And thinking about, we've had 3 students this year who have been placed in a hospital because of mental illness. And so the cost of that is astronomical. There's a documentary that Ross Green has done, and it's called The Kids We Lose, and it comes out of Maine. It was shot in Maine. And in that documentary, he shares some costs. 1 year of public school in Maine for a student is $12,509. 1 year of alternative school, which is what often happens to our students with behavioral challenges, is $23,000 to $50,000. 1 year of therapeutic residential school, so if the child's not successful in public school and they have to be placed in alternative school, the price goes up. And then if they have to be placed in a therapeutic residential school, the cost of that is $50,000 to $150,000. And then 1 day of psychiatric hospitalization is $3,393. But I would like to say that life is worth more than dollars. But unfortunately, we do have to look at the things of what things cost. Because the kids that come into my school every single day, those kids are our future. And we owe it to them to give them all we can. I just wanted to close because I felt like my call here was to be the voice for teachers who are in the classrooms every single day. And that was really the focus of the conference that I went to, is equipping teachers. So I just wanted to close with the thoughts of a teacher who has been in the classroom for 15 years. She said, "As a teacher with 15 years of classroom experience, especially with children who have suffered from trauma, I know firsthand the importance of social and emotional well-being. I have struggled to help students who were not ready to learn due to circumstances life had given them. As a teacher, I have not felt prepared to meet these students' specific needs. As more information is gleaned on the brain, its development, and how trauma impacts it, teachers will be better equipped to meet the needs of all learners. As a teacher, is it really fair for me to hold all of my students to the same expectation when all of my students have not received the same nurture and care as they have developed? They have not shared the same life experiences, good or bad. The student who sits in my classroom who has suffered great loss due to death of a parent and later death of a grandparent who has raised him. The student who sits in my classroom having been removed from his mom due to her drug problem. The student whose mom was not home last night and there was no food on the table and no one to tuck them in. And so the stories go. The students whose parents got divorced and then mom turned to drugs to cope with feelings of inadequacies. The homeless student who tells no one that they live in a car. The young girl who carries a knife in her backpack because she does not feel safe. These students come and sit in a classroom trying to learn multiplication facts and how to identify the main idea. They come and we need to address their social and emotional needs. We need to know how to identify these needs early. We need to know how to provide support, learning, and understanding as we address these students' needs. These students need us. All students need us. But we need to be better equipped to meet their needs. If we learn how to identify, address, and overcome these needs, then education will be moving in the right direction."
Thank you so much, Dr. Henderson. Are there any questions from the committee or comments at all? Well, I want to thank you. You've given us a lot to think about. I want to thank you for your commitment every day on the front lines to children who need you.
Thank you.
Thank you. Okay, and I also want to tell you that it's not your technical problem right there. It's ours.
It's okay.
It is the laptop. And so thank you for trusting us, as you've talked about trust, because we will get those uploaded from you, and we will have them on our information. And I think we do have one question or comment, if you'll hang on just a minute.
I got a question. Thank you very much for the information. So, trying to shift, if you go to this program in your school, you're trying to shift more of the teacher's focus from academic to social, emotional. It seems like that could be construed as piling more responsibility on teachers. Are teachers receptive to spending more of their time on the social, emotional needs of the children and shifting it from academics and keeping them within the classroom doing that? I mean, I would like to hear that side of it.
That is a great comment and a great question. And the way that would look is just small changes. For example, we have several teachers who are having morning meetings where they're taking like the first 5 to 10 minutes when the students come into the classroom, and they just have some kind of topic of discussion, or how was your night? Just that time to build the relationships. So no, it's not something that takes extra time. It's just a different focus to where, we're focusing on building the relationships first and helping the students to feel safe first. Something as simple as standing outside your classroom as the kids are coming in and giving them a high five, or, hey, how was your night last night? Oh, you did great at that basketball game. We're just talking about small changes like that. And then so if you really work to build the connection piece to begin with, then when that child does act up or something does happen, there's the trust there, and the child's not as likely to shut down. So we work to build that first, and then it's a shift from when the child does shut down, because this happens, when a child does not feel safe, they are going to fight, they're going to flight, or they're going to freeze. And very often what we see is that the child freezes. So something as simple as what I've been trying to teach or let our teachers know is when you see a child that has just completely shut down, to step away and give them some time, and that's what happened in those two examples, that the teachers stepped away, gave them some time, and then the child was able to finish their work. When if you had not done that, or you had not looked at it through that perspective, the child never would have gotten to the work.
Do you know if we're teaching that, or should we be teaching that in our universities for our new teachers coming into the profession?
I do not believe that we are, and I can say that just in the interviews that I've done when I'm hiring new teachers, when I'm asking those questions, I'm not getting the kind of answers where the teachers are learning to build as teachers, we go into education because we want to have a relationship with students,
Right.
But we have to be more intentional, because a lot of our kids come relationally deprived. So we've got to, work to fill that bucket. So I do not believe they are, but yes, I absolutely believe that in post-secondary education, our teacher candidates need to be learning that.
Thank you.
Thank you.
Thank you.
Great. Thank you for that recommendation, too. We will take that as a strong recommendation from you as well. Okay, and like I said, we will get all of those. I'm so sorry. You did so well in spite of our IT challenges here. So next up, we are going to hear from Dr. Anita Brown. And what a perfect follow-up on workforce after that conversation. I believe, as Dr. Henderson said, awareness is the first step, but we cannot stop there. The cost of inaction is more than we can continue to pay. The workforce has been an ongoing conversation throughout this time, Dr. Brown, and so I hope you'll help us even learn a little bit more from your perspective.
All right, thank you.
And if you would introduce yourself a little
Yes.
bit, because I don't have any of your bio.
Thank you.
info.
I am Dr. Anita Brown. I'm the Director of Professional Affairs for the Georgia Psychological Association. I am a clinical psychologist by training and education and practice, and I come here on behalf of the Georgia Psychological Association with a prepared statement. Workforce and children, other than the one that I birthed, are not my area of expertise. I'm standing in for Dr. Jennifer Staplewax, and I'll bring some acknowledgments from her as well. As a society and state, we are learning to elevate the importance of mental health needs of children, adolescents, and adults, recognizing mental health's significance and relationship with our physical health and functioning. However, we must pay attention to the mental health needs of Georgia's youngest citizens, and Georgia Psychological Association thanks this commission for its work thus far and the ability to finally present. I am here today but can never replace the input of one of our member experts, Dr. Jennifer Staplewax. She sends her regards and gratitude for you keeping her and her family in your thoughts, and as we understand it, your prayers when she was unable to be here last time. As this committee has heard, Georgia's infants and toddlers are not without mental health needs. Their brains are developing at faster rates than any other time in life. Infants and toddlers are learning critical attachment patterns and emotional behavioral regulation skills that can serve them throughout the lifespan, allowing them to form healthy relationships with others, gain and sustain employment, and contribute to society. As you have heard from previous presenters, we know an awful lot about early brain development occurring in the years between birth and 3 years old. We need to go little further than the Harvard Center on the Developing Child, firstwordsproject.com, and a multitude of studies in neuroscience to suggest and in fact indicate that what we do in the early childhood makes a dramatic difference. I urge you, in spite of everything, not to lose focus on the 0 to 3 year time span, because it really does lay the template for everything that follows. You have also heard from other panelists about the many appropriate infant and toddler mental health services in Georgia that will help to identify developmental risks and address them before serious problems develop. However, as you know, mental health support for infants and toddlers, as well as their families, requires a skilled workforce. Expertise is required in the attachment patterns within child-caregiver relations, the science of early brain development, the emotional needs of culturally diverse families, the navigation and knowledge of access resources that are available to address the complex needs of challenged families, the therapeutic approaches that empower parents as teachers, and the ability to collaborate and integrate disciplines such as physical and mental health providers, early care and education systems, and social support agencies. So where are the psychologists in this? We consider ourselves to be force multipliers. The area of psychology and the discipline that mostly focuses on children has many facets. Developmental psychologists are mostly scientists. There are also child psychologists, educational psychologists, school psychologists. We are often not at the front lines of providing care directly to infants and toddlers. However, we do prevention, we do research, both in terms of science-based research about the programs and interventions that will help, as well as program evaluation research and outcomes research. We certainly do training, and as I said, a relatively small proportion of practicing psychologists do actual hands-on treatment with this population. At this time, Georgia lacks the much-needed workforce to meet these mental health needs. Children ages 0 to 4 represent, as I'm sure you know, over 25% of children and adolescents within Georgia. So I'm going to outline 3 areas that Georgia Psych Association sees as being important to the concept of workforce development. First, prevention. With record numbers of babies being born prematurely, many of them experiencing health disparities, psychologists bring a deep knowledge of early childhood development, factors of health disparities, the impact of these factors for screening, assessment, diagnosis, and intervention, many of it well before any diagnosis is needed or any pathology is noted. In effect, what we're talking about is prevention. Enhanced efforts to educate the workforce on infant-toddler mental health is preventative. Institutions of higher learning should be encouraged to provide pre- and post-service training for parent educators, early care and education providers, nurses and physicians on screening and identifying the mental health needs of Georgia's infants and toddlers. This will help to decrease the stigma, we just heard a little bit about that, that's associated with mental health problems and the fear of labeling children at such a young age, increasing young children's access to mental health services and helping to prevent things that may occur later on, such as beginning kindergarten and in school and at the juvenile justice age, before they even become significant problems. So, incorporating pre- and postdoctoral education and training for our many service providers in training. Second, at the most acute level of mental health needs, infants and toddlers may require the expertise of mental health professionals such as psychologists and others. However, there is a shortage, as we know, of such providers. For example, even within the Georgia Psychological Association, only about 6% of our member psychologists identify themselves as working with infants and toddlers, as compared to 40% of our members identifying themselves as working with children and adolescents. This demonstrates the relatively small number of providers available to meet the needs of Georgia's youngest children. Therefore, we encourage, once again, specialized training, continuing education training in infant and toddler mental health, and encourage strongly that any kind of training that's done needs to focus on infants and toddlers as a subpopulation where training is important. We find that one of the barriers to providing the actual treatment that's necessary is because there's not enough Medicaid reimbursement for mental health services for Georgia's youngest children. And it's not available to increase the existing workforce's ability to service these children in a financially sustainable manner. This includes allowing for services for children without a formal DSM-5 or ICD diagnostic label, and to provide for preventative services and to avoid premature labeling. What we can say, and this is a very brief statement, is that psychologists stand beside our colleagues in being frontline researchers, as well as trainers, as well as evaluators of programs that do work. And there's a plethora of programs that we know work. It's in their implementation and their disbursement and their reimbursement where we see the biggest problems lying. We emphasize the importance of prevention, assessment, diagnosis, and of course, intervention. Our greatest approach, our greatest strength, is in providing a universal approach to all babies and their families so that the problems never have a chance to get started. Thank you. I welcome any questions. I may retain the right to get back to you with a written answer from our experts, but I'll field whatever answers I can.
Thank you so much, and we appreciate you being here. I know it was kind of short notice when Dr. Staplewax, again, couldn't be here, so we appreciate it. And those were great, very pertinent comments, so thank you for it. Very thoughtful. Are there any questions or comments from our legislators? Well, I think you gave us some very good information.
We're happy to receive questions and
well,
respond. Thank you.
And you have been great to work with all
right.
along
All
as
right,
an
thank you.
association, so I appreciate you very much.
All right, thank you.
Okay, so now to our next presenter, Dr. Dan Edwards from Evidence-Based Associates. He is the Senior Director of Corporate Development and Business Development for Evidence-Based Associates. We've heard throughout these presentations how important evidence-based work will be to any of the steps that we move forward as a state. EBA helps states and localities drive high-fidelity implementation of evidence-based programs, EBPs, including a partnership with the former Governor's Office of Children and Families. Dr. Edwards will tie workforce development into the Families First Act. So thank you so much for being here. Dr. Edwards, if there's anything else you want to share about yourself, we're certainly open to that, but anxious to hear your information. I believe there is some information in your packet as well.
Great, thank you. So will there be the ability
We're
to...
trying.
Okay.
We're trying.
All right. I do see members of the committee have
We do.
the hard copy. Okay. All right. Well, good morning. Thank you for the opportunity to talk with you a little bit about evidence-based programs. And as Dr. Brown just mentioned, it's not just the programs themselves that are important, but the way in which they are implemented. And I'll be talking a little bit about implementation issues as well today. I have also a clinical psychologist. I have a degree from the University of Florida. I guess it's good that we lost this year so that nobody walks out. All right. My dissertation was on one of these evidence-based programs that you've heard about, parent-child interaction therapy. I worked with the developer, Dr. Sheila Eibert, on that program. I worked for 10 years in Charleston, South Carolina with the, I think you also talked about multisystemic therapy, and I was a vice president for program development with multisystemic therapy. And today I'm living in Alexandria, Virginia, a couple miles south of Crazy Town. But working to lead EBA and to work with states all across the country in implementation of evidence-based programs. So I'd like to suggest that we follow the science and the evidence to do what we can do to help children and their God-given families to thrive during precious early years. The Casey Family Programs estimated that there are about 100,000 families each year receiving services in Georgia as related to an allegation of abuse or neglect. It is likely that a very small percentage of those programs are evidence-based, and so there's definitely room for improvement. I want to promote the idea that we select the right programs to do for the right kids at the right time, but also implement them in the right way. Okay, next slide. So I'm the senior director at Evidence-Based Associates. We're a small but mighty organization, about 15 full-time staff, and the staff live and work in the states where we have projects. We have projects in Florida, Georgia, Virginia, and DC at the moment. Our first project was in Florida in 2004. We worked with the Department of Juvenile Justice for about 10 years. We served about 10,000 children with evidence-based programs. Personally, I have about 23 years of experience working with evidence-based programs in both juvenile justice and child welfare. Our organization focuses on 7 different aspects of the implementation of evidence-based programs. If you will, the TA and QA, the technical assistance and quality assurance aspects. So partnering with system champions, legislators and reformers like yourselves. We work with the local provider organizations, usually under a subcontracting arrangement, so we provide them with training and support to be able to deliver the evidence-based programs. We work with the counties to develop referral processes to make sure that the right children are being referred to the right service. We provide data collection and reporting, fidelity monitoring and program evaluation support, and accountability and transparency in the fiscal operations as well. One of our mottos is we're trying to help states do the right things and do things right. So it's picking the right program and implementing it, as I said, in the right manner. So we've been a partner with the state of Georgia for about going into our 7th year now. We have been working with the Criminal Justice Coordinating Council for the past 7 years and about 12 different counties across the state. And our partnership so far has focused on young people involved with the juvenile justice system and their families. In 2012, I believe the Georgia legislature proposed and in 2013 passed the Juvenile Justice Reform Act. Part of that was the Juvenile Justice Incentive Grant Fund, JJIGP. Governor Deal, the Pew Foundation, Casey, and the Georgia legislature were the architects, if you will, of this plan. And the goals were to reduce the percentage of children being placed in out-of-home placement or incarcerated or put into residential treatment centers. And the idea was to give judges the option of referring youth that were at high risk of future recidivism by providing the family with evidence-based programs. And so we've seen a dramatic reduction in the number of kids being placed out of the home as a result of that bill. So one of the things that was included was a list of evidence-based programs, much like you had talked about, Melissa had talked about earlier, with the federal government now coming up with their list. The state created a list of 7 evidence-based programs that counties could select to implement. And that project has gone very well. We've been able to, the money was available to counties, as you probably know, that were the ones that were placing the most kids. So the 25 highest placing counties were eligible. And they competed for funds to be able to implement these evidence-based programs. About half of the counties chose to work with my organization, Evidence-Based Associates. The other half chose to do it on their own. And it's been a very interesting experience of watching as states implement, as counties across Georgia implement these evidence-based programs like MST and functional family therapy. Again, half of them working with us and half doing it on their own. Before I tell you how it's gone and what the results look like, let me just say, next slide for those of you that are following. Should we assume that EBPs always work? It sounds great, right? Evidence-based programs, science-based programs, they ought to work, but they don't. And the first case study of evidence-based programs being implemented that didn't work, or one of the more classic examples, was actually in New York City. There was a pilot project funded by Goldman Sachs in partnership with the Bloomberg Foundation, somebody who I think just filed to run for president, and then with a local large provider organization called the Osborne Foundation. So they teamed up to address the issue of kids at Rikers Island who were at high risk of recidivism and continuing to cause problems in the community, and to provide them with an evidence-based program as they were on their way back, returning back to the community. Lots of money spent, lots of really smart people working on it, and it totally failed. Within a year, they had Vera Institute had evaluated it and decided that it needed to be shuttered and wrapped up and closed down. Why? What was the problem? The problem was they chose an evidence-based program. It wouldn't have been on my list. It's not on your Georgia list, but they chose an evidence-based program that was really appropriate for low-risk kids. And it's appropriate to be delivered in the home setting, not in a prison. So they picked the wrong program for those kids and delivered it the wrong way. It was a very bad decision on two fronts. And so that was the first failure that I wanted to bring to your attention. The second one on the next slide is an evidence-based program that was the right program for the right kids. Functional family therapy was tested by the Washington State Institute for implementation in Washington State, matched up to the right kids. Actually, a very good study looking at how well FFT worked for kids on probation. And what they found was that on average, it didn't really have much impact. And this happens in a lot of studies. This is one that was widely published and disseminated. The problem was that the therapists that were learning how to do FFT, it's a very, I don't want to say sophisticated, but it's a master's level therapist with a degree in social work or marriage and family counseling that would deliver the program. About half of them really got the model, and they were delivering it with a highly competent therapist, delivering it with, as Representative Dempsey mentioned earlier, fidelity, one of her favorite words, one of my favorite words too. The therapists that delivered the program with high fidelity had dramatically better results than the comparison group, and those that delivered it with poor fidelity had dramatically worse results. So what have we learned? One thing is you have to pick the right program for the right kids. The second thing is even if you pick the right program, you have to deliver it with fidelity. And I think those were some of the implementation issues that folks had hit on a little bit earlier. So now back to the Georgia story. Next slide. Those that are in the room here can't see this big picture, beautiful picture of Governor Deal and former DJJ Director Avery Niles. A wide array of folks here that are all celebrating the receipt of an award called from the National Criminal Justice Association for the Outstanding Program of the Year award 2 years ago. So it has been a widely appreciated success story. You've reduced your out-of-home placement rates by 60%. You've saved a lot of money. Kids are doing better. The one final word on that, the next slide, is the fiscal year 2017 out-of-home placement rates for all the counties that participated in the project. On the right side are the counties that adopted a top-tier, highly supported evidence-based program like FFT or MST, but did the implementation on their own. On the left side are the counties that also received implementation support from evidence-based associates. And what you'll see is that on their own, the counties did a good job of reducing out-of-home placement rates, about 46%. That's fantastic. But with a little bit of support to the TA and QA support that I talked about earlier, the counties that we've been working with had an additional 20% drop in their placement rates. So this is actually, I think, the first time that there's been evidence. There's a whole field of implementation science growing, but this is the first time I think that there's evidence that implementation science in the real world has actually made a difference with kids and families. Okay, next slide. Are we doing good? We're doing all right? Right. So I've heard mention of ACEs, and of course ACEs is, I think, part of what drove the state to make the decision to form the study committee and to look into these issues. And ACEs is very well known now. These adversive childhood experiences predict all kinds of bad outcomes for kids and for families. I think a study just came out last month by Kaiser and the CDC again, showing that 5 out of the top 10 reasons for the causes of death in this country are related to ACEs. The risk level goes up dramatically, significantly as a result of the ACEs. There's obviously issues like heart disease and obesity, but also mental health issues like depression that are all related to ACEs. So what can we do? The next slide talks about what the CDC and the Kaiser Family Foundation are promoting, and I think these are widely accepted recommendations. So the print's pretty small, but things that Melissa talked about, the focus on families and early intervention and mental health programs and substance abuse programs are all captured in these recommendations endorsed by the CDC. So let me go to the next slide to talk about these a new resource that's out from the CDC. It's called Preventing Adverse Childhood Experiences, Leveraging the Best Available Evidence. What's really interesting right now is there's this convergence from the scientific community and from the federal government with regards to the FFPSA that we know what we need to do for these kids. We know that there are programs out there like Representative Oliver mentioned earlier about Nurse-Family Partnership, for example. That's a classic evidence-based program with 20, 30 years of research behind it, a global footprint. It's implemented in pretty much every state and in many countries around the world. And we need to find ways to make that work in the real world in communities all across Georgia. I'm here to say that the stars are aligning. The local policy experts, the CDC, the scientists, and the federal government are all aligned, and it's a great opportunity to move into these in this direction with these programs. So, for example, home visiting programs, one of the things that has happened in our field in the past 20, 30 years is we've realized that families that need the help the most are the least likely to show up in our clinics and in our hospitals. We need to go out to them. And so almost every one of these evidence-based programs that I'm going to talk to you about today is a home-based program with in-home delivery. So home visiting programs for pregnant women and families with newborns, such as Nurse-Family Partnerships, is a strongly recommended program. Parent training programs like Parents as Teachers for 0 to 5 or PCIT for 2 to 6. These are also programs that are well supported by FFPSA and recommended by the CDC. My last bullet point there are a couple other programs to consider like Incredible Years or Triple P, but you have one here at Georgia State that is also an emerging program with very good evidence behind it called Safe Care. And it has published a few studies, but I don't feel like the findings in those studies have been like publicized or marketed as much as they should. They have dramatically reduced risk factors in the home. One of the things that they're known for doing is safety assessments in the home to find things that might cause children to harm themselves or be harmed by things in the home. And so by working with families, they can reduce those risk factors, those safety issues dramatically. All of them are family focused, all have been widely studied, and as I said, nearly all of them are home-based. Next page. As Melissa said earlier, the family-based mental health and substance abuse treatments like functional family therapy and multi-systemic therapy are both recommended by the CDC and the FFPSA. And by the way, these are the programs that the CJCC has also been funding. So you already have in about 20 counties right now either an FFT program or an MST program. Now they are set up to serve kids in the juvenile justice system. But I can speak on behalf of at least the programs that EBA oversees. Many of those programs are being underutilized right now. There is capacity to take additional referrals for families that either have a child that's in the 11 to 18 age range that might be causing problems at home that is leading to them being at risk for an out-of-home placement, or families where there is a substance abuse or mental health concern that's presented by the parent. Then the last set of recommendations that I wanted to share with you this morning are another interesting model promoted by the CDC, which I have not seen yet at FFPSA, but it's called SEEK, S-E-E-K, the Safe Environment for Every Kid model. Actually focuses on the primary care side. So physicians, pediatricians are trained to go through screenings for safety and for concerns about the family environment where trauma might have occurred. And there are also evidence-based victim-centered services for women with a history of partner violence that the CDC recommends. The next two slides were to give you a brief overview of the FFPSA, but I don't need to do that this morning. It's already been done. And so the final slide, I think, is a sort of a recap of where we are and what I think lies ahead for Georgia. As was discussed earlier, the Department of Family and Children Services is developing an effective strategy that will facilitate the effective implementation of FFPSA, improving, I think it's a quality and quantity issue, more evidence-based programs, higher quality evidence-based programs, community-based, family-centered programs, which will allow us to decrease the number of children going into foster care, just as it has decreased the number of children going into the juvenile justice system over the past 6 years. It will improve outcomes for at-risk kids and reduce the costs to Georgia and to the federal government associated with foster care wherever and whenever possible. For the study committee, obviously, to promote public policy that will improve the lives of our youngest children, I think, number one, by tackling these ACEs. How do we address the issue of adverse childhood experiences in that 0 to 3 age range? And I think that's best with evidence-based programs that are delivered in the home. Discovering the best available evidence. We have 5 or 6 programs now that are listed on the well-supported and supported list from the FFPSA group. But as Melissa said, there are 20 or 30 more under review. So keeping up with the new programs that are supported by the FFPSA group and figuring out how to direct resources there as well. Strengthening key partnerships and aligning our best resources with our best opportunities. Thank you.
Excellent, Dr. Edwards. We've got a question for
All
you
right.
right now, and I believe, is it Representative Oliver? Okay.
Is for you, sir, and really for you, Madam Chair. I don't see anybody on the agenda that's going to be able to explain to me how Medicaid funding overlaps with Babies Can't Wait and the new Families First money. And I use the nurse family program, what I used to know about that, and about Safe Care.
Mm-hmm.
I don't know that either of those are supported by Medicaid. And I don't know how many children, I've heard a lot about Safe Care, but not recently.
Mm-hmm.
And
Right.
I don't know how much they're in the field, and I don't know whether they're being supported by Medicaid.
Yeah.
This funding stream is what's got me really confused. And who today can answer this question? You, sir?
I could talk a little bit about it, but it's not. So Safe Care, as I understand it, is funded through Safe and Protected Families. Is that the name of the funding? But they have seen a reduction in the number of communities and counties that are adopting Safe Care. So I think that those are classic implementation issues. I went through it very quickly, but those 7 different areas, meeting with judges, meeting with community-based, and juvenile justice, meeting with the prosecuting side and the defense side, and making sure we all understand what these programs can and can't do, and make sure we direct children in the right direction. When we were in Florida, you mentioned as well risk assessment. Risk assessment at the front end is so important, so we know the highest risk kids get the most intense services and so on. I think there's some work to be done around the implementation of Safe Care in that regard. As far as the federal government, I do know that there was a webinar not long ago. Interesting title. It was When Entitlements Collide, and it was this whole issue of Medicaid meeting Title IV-E and how do they play well with each other. After about a year, as I understand it, of conversation in D.C. and with the stakeholders, it was determined that Title IV-E would be the payer of last resort on all of these programs. So if children were eligible for Medicaid and the services were under code, state code, then Medicaid would be billed first.
Well, that makes sense because we have a less of a state match for Medicaid than we do for these other programs in many cases, in all cases. I don't know about CHIP, but I really want to expand our services, but Medicaid is our payer of first opportunity, and the new Families First program doesn't explain to me how that's going to work together.
And this is not my organization, but we are partners with an organization that is expert on the funding strategies, and I'd be happy to put you in touch with them or put them in touch with the committee.
I mean, is
In
it
fact-
half the children are covered by Medicaid?
I think that would be great if you could put us in touch with that
Okay.
information,
Yeah.
particularly because this
Yeah.
is a burning question that has come up since the very first meeting that we held. And I know even beyond this time, it's something that you ask in our appropriations subcommittee as well, Representative Oliver, and I appreciate that.
May I ask one question about your slide 7? Reduced DJJ placement rates. I'm assuming you mean reduced out of detention centers. But are you talking about placement rates in group homes too? I assume this is talking about secure beds.
Secure beds, exactly.
Okay.
Broadly defined. Yeah.
So if there's been a 65% average in reduction of secure beds, have we redirected some of that money, or is the state just taken that money in to pay for whatever else they need to pay for?
I don't want to speak on behalf of DJJ, but I believe most of the funds that have been saved have been redirected back to other projects in DJJ. So upgrading facilities, potentially staff salary increases, things like that.
Well, I don't think it has gone for salary, but that'd be
I
interesting
don't
to
know.
know.
I don't
I'd
know.
like to know that. If they've had a 65% reduction, their beds have gone from 1,100 to 500, roughly,
Sounds
is what
about
I,
right.
roughly.
Yeah. Sounds about right. Yep.
That's $100 million. So where we use that $100 million in some positive way? Is it gone to DNR? Is it gone to
Yeah.
Medicaid? Or
Well, I will say in Florida we saved huge amounts of money, but that was primarily because the Florida juvenile justice system, and I believe the criminal justice system, operates on a private contract system. And so if they don't use a bed, they don't pay for it, they save the money right away. Most states like Georgia, there's a publicly run system of residential centers and prisons and jails. And so the only way to really save that money is to close a facility. You could avoid costs by not having to build new ones, but that's cost avoidance, not cost savings.
final question, if I may.
Yes.
This picture here with Governor Deal, Outstanding Program Award.
Yes.
That program was one program or multitude of programs? And was it all administered by Criminal Justice Coordinating Council?
Second question is yes. You're asking, was it the only outstanding program award given that
No,
year?
did it go to different kind of service programs, or did it go to one kind of service program? Or was it just all under the label of redirection?
No, let me check that and get back to you. My understanding is that that was the award winner that year for community programs nationally.
Okay. Thank you.
Okay. I don't see any other questions or comments at this time. Dr. Edwards, thank you so much for being here and for sharing. I do have one, because you've a lot of numbers about a lot of different programs. So do you know how many, an estimate of how many programs in Georgia are evidence-based today? It's a big question, I know, but just to kind of plant that.
I don't know if DFACS has finished their review, because I believe the first step in their strategy was to do an assessment, and I don't know if that's been completed. The national average is between 5 and 10% of all of the money that's being spent on services for children involved with the child welfare system is between 5 and 10%. Florida just finished their review using the old standards from, you mentioned different registries, the California Clearinghouse. 6% of the programs that they funded were considered evidence-based using the criteria from the California Clearinghouse. So if you do have a survey or a study going on, I would expect that to be a very low number, unfortunately.
So we have much work to do
We do.
still in Georgia.
Thank you.
Thank you so much for your presentation. We are going to take a brief pause here and change out a laptop, but I want to tell y'all, I know everybody may need a minute or two break anyway, and we'll come back, but we are going to have some, I think, of the most profoundly informative presentation that's going to be ahead of us right now. We have a neighbor, Alabama, who has found a way to do this in a great way, and I need to learn about it. I think there's much to learn from, but this can be done. So everybody take a quick break. We're going to change out the laptop and be ready to go again in just a few minutes. Okay, as soon as we can get everyone back and in their seats, I think we'll be about ready to hear this excellent presentation coming up. Yeah, okay, great, perfect. Okay, so this will be my first time also to hear live and in person about some of the great work that our neighbor in Alabama, some of the great work they are doing. Dallas Rabig, the state coordinator of infant and early childhood mental health endorsement coordinator for the First 5 Alabama and child trauma specialist, I believe is going to be here. Ms. Rabig works collaboratively with these state departments and community agencies in Alabama to build and implement infant and early childhood mental health capacity throughout the infant and early childhood systems in the state of Alabama. In addition to discussing with us how Alabama has structured this system, I hope that you will explain how you chartered the Alabama Association for Infant and Early Childhood Mental Health for the First 5 Alabama, I believe is what it's called, and adopted the competencies and endorsement from the Alliance, competencies and endorsement from the Alliance for the Advancement of Infant Mental Health. A lot of good work, it sounds like. We're anxious to hear about it. Thank you for being here with us today.
Well, thank you, Chairwoman and Committee, for having us here. We were really excited to get the invitation to come to the microphone. And can you hear me now?
Yeah, that's great.
Okay. You would think as a vocalist for the National Guard I could work a microphone. Okay, so I'm going to talk to you guys, share with you about our infant and early childhood mental health system of care and how it came to be. So briefly, I would like to go over our infrastructure timeline and how that happened, because it did happen in a fairly short amount of time. So in 2014, Alabama was awarded a Project Launch cooperative agreement grant along with Georgia and 13 other grantees. We had the privilege of getting to know the Georgia Launch grantees as well during our 5-year period under this grant. One of our focuses under this grant was infant and early childhood mental health consultation, and that was the main piece that we piloted throughout the 5 years in Tuscaloosa, Alabama, and actually in Tuscaloosa County, but we were housed at the University of Alabama in Tuscaloosa. Roll Tide, I love you guys anyway. I'm sorry, I had to throw that in there. So in 2015, when I came on board with Project Launch. I was in Colorado working in infant and early childhood mental health when Project Launch came calling and needed someone to come and build a model for them and to implement it in their pilot sites. So we began to develop that model and implement it in early intervention, home visiting, first class pre-K, which is our state-funded pre-K program, and early care settings. And in the 5th year, we implemented it in our integrated behavioral health model in a pediatric setting. So in 2016, year 3 of Project Launch, the state coordinator for infant and early childhood mental health position was created. And it was created in partnership with the Alabama Department of Early Childhood Education. Our federal GPO for Project Launch agreed to allow Project Launch to pay half the salary to fund it throughout the end of the duration of the grant. The grant ended the end of September of this year, and the Department of Mental Health agreed to pick up the other half, the half of the salary. So now the Departments of Mental Health and Early Childhood Education fund my position. In 2017, Alabama Partnership for Children secured funding from W.K. Kellogg to launch First 5 Alabama, which is our Alabama Association for Infant and Early Childhood Mental Health. So from this point forward in the presentation, it will be referred to as First 5 Alabama. This established a platform for implementing a set of competencies and endorsement and opened the conversation with Alabama Medicaid around possible or potential billing practices and policy changes. In 2019, in January of 2019, the Alabama Department of Human Resources funded the first cohort of 6 infant and early childhood mental health consultants to be placed in licensed early care settings to serve those providers. This was our first expansion effort from the work that we did through Project Launch in Tuscaloosa. During this time, we also established an infant and early childhood mental health consultation advisory council to guide our implementation activities. We meet quarterly to determine what workforce development needs that the consultants may have, potential funding resources to expand consultation, and the members consist of folks from various different agencies, whether they're state agencies or nonprofit agencies. Our consultants within the first 9 months or the first 6 months served 39 children and families, 34 licensed early care programs, and prevented 5 children from being expelled from their programs. Also in 2019, the Alabama Department of Early Childhood Education was awarded the PDGB-5 grant, which is the preschool development grant, Birth to 5, in the amount of $10.6 million to help us develop infrastructure throughout the state. Part of that money, what we wrote into that grant, was supporting mental health efforts in the birth to 5 and perinatal mental health populations. And so some of the ways that we are using that money is that we developed a partnership with Troy University to develop a graduate career path where they will be developing 4 undergraduate courses in infant and early childhood mental health, 5 graduate courses in infant and early childhood mental health that will be accessible as electives for the first 2 years to early childhood development majors, early childhood education majors, human services, social work, nursing, and mental health. We are hoping that this will increase the number of licensed clinicians. That's in the wrong place, sorry. That this will increase the number of clinicians coming out of programs who are educated in infant and early childhood mental health, as well as teachers and early childhood educators. Some of the folks that will have access to these programs will be people that will be employed in home visiting, such as parents as teachers and nurse-family partnership. We're also hoping that this will influence those in early care settings who have earned their CDA to move forward with a bachelor's degree in early childhood development and seek to take the courses in infant and early childhood mental health, which will increase the knowledge and skill base of our early care providers. In 2019 as well, that our chairman of the House Ways and Means Committee created a new funding stream in fiscal year 20 Education Trust Fund to implement our new infant and early childhood special programs, which is housed through the Alabama Department of Mental Health. We are using that as a vehicle to build our system of care, which includes mental health consultation. So the folks that are working as a team under this program are Jane Dewar, which is the director, and she has an early intervention specialty. She comes out of being a director with early intervention. Sarah Ellen Thompson, which came with me, she's our project manager, and she's housed at Alabama Partnership for Children. Myself, who is the state coordinator for infant and early childhood mental health at the Department of Early Childhood Education, and we have just hired something very new, the first state to have one, is a reflective supervision state coordinator, and she is housed at the University of Alabama. She was one of the mental health consultants in our pilot, and we were able to sustain her position by giving this particular role to her. And what she will be doing is building capacity in reflective supervision and consultation across the state, across multiple disciplines and sectors. And if you haven't heard what reflective supervision and consultation is, It is the driving force behind infant and early childhood mental health. And it's the driving force behind supporting the workforce in the emotional content of the work because it is emotionally draining. We're hoping to support child welfare, so Child Protective Services caseworkers with reflective supervision and consultation. We test piloted a small group in Chambers County, Alabama, where we saw improvements in how caseworkers thought of their families, being able to look at their families through a trauma-informed lens and through an infant mental health lens. The reflective supervision also supports home visiting. It is required now for parents as teachers, Nurse-Family Partnership, and Healthy Families America, all three of which we have in our state. So in 2019, the advisory committee and First Five Alabama recommended creating the First Five Consultation Project. Under this is where we will identify mental health consultants, no matter who they're funded through, in regards to our state agency partners. So First Five Alabama consists of 7 state agencies. Is that correct? Now there's 8 because we've added Medicaid. So Department of Early Childhood Ed, Medicaid, Department of Ed, Department of Human Resources, Mental Health, Child Abuse, Neglect Prevention, and Public Health. There we go. Along with Alabama Partnership for Children, which is a nonprofit, and then we have some at-large board members from other agencies and universities across the state. I can't believe I did that by memory. So any of those state agencies or partners that fund mental health consultation, those mental health consultants will all receive the same workforce development opportunities through First Five Alabama. And so we started doing that this year with funding from PDGB 5. So we brought in heavy hitters to help us with workforce development to get us kick-started. So we brought in folks from Michigan, from the Michigan Association for Infant Mental Health, which we were able to do because of our affiliation with the Alliance for the Advancement of Mental Health, which is a national and international organization now. Because of our affiliation with them through First Five Alabama, we can reach out to partners who will come and help us with workforce development activities, will help us with integrating and expanding reflective supervision and consultation. So we were able to bring in some representatives from Michigan Association to provide their foundations training that they give all of their infant mental health home visiting providers. And so what this is it's infant mental health theory or theoretical practice. And so all of our consultants will be trained in that. Moving forward, they will be onboarded upon hire in some of these opportunities. So that one, and then FAN, which is Facilitating Attuned Interactions, which comes out of Erickson Institute. We just finished up with that. We will have 4 total cohorts to go through. It's an 18-month learning collaborative, and out of that we will end up with 2 trained trainers who will be able to sustain it by training statewide other home visiting visiting programs, early intervention programs, and early Head Start programs as well. And then there was one more. Sarah Ellen, can you help me out? Yeah. There was one more. Sorry. Okay, I'm going to move on, and then I'll think of it. So what we're wanting to do with this is it increases consistent messaging in our delivery of service. We also have our legislative funding of infant and early childhood mental health. So in 2020, the legislature gave us $500,000 to fund 8 additional mental health consultants. These consultants will serve early intervention and first-class pre-K. 2 of those consultants will pilot a perinatal mental health consultation model that we have partnered with UAB, which is the University of Alabama, Birmingham, and their substance use program called the CAP program, which is Chemical Addictions and Pregnancy Program, where we will pair a perinatal mental health specialist with, we've got 2 homes that serve pregnant women and their children in treatment in those homes, and then the other perinatal specialists will be in a high-risk community where we're seeing high recidivism rates of women coming out of the program. So one of the things that has helped us advance us quickly is that we were awarded the opportunity to participate in the 0 to 3 financing policy project last year. We were selected with 9 other states, and this really, there was a previous cohort of 10 states, so we were able to learn from their successes and their barriers in order to put together a plan on how we wanted to advance policy and financing that policy in the state of Alabama. Part of the requirement for earning that was that Medicaid had to be at the table. And so we strategically chose Kathy Hall, which is the she's the Deputy Administrative Director at Alabama Medicaid. And so she was on our team along with myself, Sarah Ellen, and our legislative liaison and director of early intervention. And we had a convening in Minnesota, and it was there that she had her aha moment. And it was there that she looked at us and said, we only thought we were treating infants and children. Now we've got to go back to the drawing board and really look at what we're doing. And so once we got back, we were able to pull some data and analyze that data to see what was really going on. And to kind of back up, before then, back in 2017, we did a landscape survey of licensed mental health providers and what they were doing, what they were billing for, the age ranges that they were treating. And what we found was that for the most part, children 5 and up were getting treatment, and they were getting evidence-based care. So they were getting trauma-focused CBT, which is cognitive behavioral therapy. Some were getting PCIT. However, what we found was between 3 and 5, we were seeing some play therapy if children 3 to 5 were getting treated at all. And then from 0 to 3, there was nothing other than medication. So we were seeing these children being treated through psychiatric treatment. And these were ones that were coming through the UAB Children's Mental Health Unit. So we were able to meet with Medicaid, Alabama Medicaid, and talk to them about what is developmentally appropriate in assessing and diagnosing children birth to 5. And we introduced them to the DC 0 to 5, which is the diagnostic classification of mental health disorders of infancy and early childhood. From that, we talked about what might happen down the road in about 5 years and what it was going to take to be able to implement that into billing policy. And so we moved forward with training, having 2 individuals trained in the DC 0 to 5 with the goal of having them become trained trainers once that once that opportunity became available. So we were able to do that, and now we have 2 trainers in the DC 0 to 5, and now we have the Alabama Academy of Pediatrics who is on board with helping us message this to pediatricians. Medicaid came to the training, and their eyes were opened as to what is appropriate for diagnosing children birth to 5 and what that entails, and how we don't slap a label on children. We're diagnosing a relationship. And we're also looking at at all different factors. We're looking at the psychosocial, the whole child, the whole family, and what those needs are using the DC 0 to 5. Through this, we were able to enter into conversation, developing a crosswalk for our billing practices and what we bill for here, in Alabama. So one of the things we were able to do was to look and see what billing codes that were being used most often and who was doing that. Through that conversation, Medicaid agreed to open up Medicaid provider status to our licensed professional counselors and associate licensed counselors, our LICSWs, and our LMFTs, which are our licensed marriage and family therapists. So by doing this, it increases equitable access to care across the state for our children and families. In addition to that, previously, LPCs and ALCs were not allowed to assess, diagnose, and treat without being signed off, their work signed off on by a licensed psychiatrist or psychologist. Now they are completely independent practitioners, and they're able to do all of that and bill for Medicaid under their own provider number. In addition to that, Medicaid agreed that from the ages of birth to 5, that they would increase the number of visits available before making a diagnosis. So our ALCs and LPCs now have up to 5 sessions before making a diagnosis on that child. And that is best practice. So when we looked at, I just said all that. So when we looked at policy, the relationship with Medicaid was the key to think about what we needed for workforce development. So one of the questions came up is, hey, if we change policy, how do we know that the workforce is gonna be there to implement these things? And so when we knew what Medicaid was going to support us in was when we decided what trainings and workforce opportunities we were going to bring to the table, bring to Alabama. And so once we established this relationship with Medicaid and they agreed to move forward with any type of billing policy changes in the future, then we moved forward with scheduling specific training opportunities. So one of the things that we were looking at is that for infant and early childhood mental health consultation, that is a preventive intervention. It is right now not a billable service in any state that I'm aware of. It's a struggle that we're all struggling with, how to, figuring that out and what the solution is going to be. What we know is that CMS, which is the Centers for Medicare Services, they're going to have to make changes to how they define consultation in order for states to be able to start billing for that service. But we were expanding consultation throughout the state. We're well underway of expanding that across the state. But what do we do with those children that don't respond to consultative services? What are we doing for those children and families who are in child welfare who need more than just consultative services? What do we do for them? Because trauma-focused CBT is not evidence-based for birth to 3, okay? PCIT is evidence-based, but the evidence is questionable birth to 3. And it's behavioral support. So a child and a family who's been through trauma, unresolved losses and griefs, neither one of those models treat that neither one of them address it. And the only model that we found that has been successful is CPP, and that's child-parent psychotherapy, and you heard about that earlier from another speaker. So we decided that we would go with child-parent psychotherapy versus those two, and Circle of Security, and there's another one, ABC, which is attachment biobehavioral catch-up. So we decided with CPP, number one, because we now have partners with the founders of that particular model and trainers. And so they agreed to come to Alabama to do it for a minimal cost. And so that, again, will be another 18-month learning collaborative. We plan to have up to 35 seats available in the first cohort, the first 18-month cohort, opening up a second 35 seats for the second cohort. The goal is to have, in the next 4 years, every county in the state of Alabama accessible to a CPP provider, with the idea that every county DHR, child welfare office will have access to a CPP provider. And so that's what we have chosen to go with. And, okay. There we go. Now, I've talked about our benefits of being an Alliance affiliate. So when we formed our Association for Infant and Early Childhood Mental Health, we got the grant from W.K. Kellogg, and which paid for us to establish the set of competencies and to purchase the Easy platform, which is the online platform by which applicants put in their application. And technically what they're doing is building a portfolio, a professional portfolio of their work. This is something that they can continue to do year after year as they renew their endorsement. And the endorsement isn't a license to provide any type of service. The endorsement really is a recognition of the work that you've done and the work that you're doing on your education, your professional development, and your work in reflective supervision. So what we have found benefits of being part of this alliance is that we're part of a national and international movement which establishes credibility in such a new field, and the field is rapidly growing. We currently have 30 states and 3 international affiliates now, so Western Australia, Ireland, and Hawaii. Well, no, Hawaii is, let's see, so Western Australia and Ireland, and then Japan is now in the discovery phase. So participation in endorsement, research, and training committees. So being part of the alliance, you have your leadership cohort has the opportunity to participate in research activities and training committees, which is helping us to develop the undergraduate and graduate coursework that we are partnered with Troy University to do. We have the Leadership Summit and Reflective Supervision Symposium, which has allowed us to increase our knowledge and skills around reflective supervision. And the Leadership Summit helps us to network and get to know each other over a 3-day period and really learn skills on how to grow our association. It has also helped us lead to systems change. So we have entire agencies that are now seeking endorsement, aligning professional development with competencies, and working toward a requirement that all licensed direct service providers be endorsed. So the Department of Human Resources has funded the first cohort expansion of mental health consultants. They're all required to be endorsed within the first 2 years. The Department of Early Childhood Education has required that all of their infant toddler coaches become endorsed with later their leadership and pre-K, first class pre-K coaches to be endorsed. Mentoring in the development of graduate level career path, and overall increase in understanding of working from an infant and early childhood mental health lens across disciplines. And Healthy Families America, I don't know if you have HFA here, but they too have a new partnership with the Alliance, which will require them to become endorsed as well in their state if it offers endorsement. All right, so this is what the map looks like right now. So if you notice, all of the green states and countries are those that are active affiliates with the Alliance who are using the competencies and the endorsement process. And if you notice, Georgia and North Carolina are 2 of our southern friends and neighbors that are in the exploratory process. All right, so some of the benefits of being endorsed from some of our first 5 endorsees, these are quotes that we've gotten from them, is that the endorsement process has helped them identify gaps in their own understanding and knowledge of infant and early childhood mental health. Going through endorsement motivated me to be a better provider. And enjoying the professional development opportunities through First 5 Alabama. And in addition to that, the reflective supervision requirement for clinicians has opened the door to conversation about implementing reflective supervision across the state. So we have several things that are going on cross-discipline and cross-sector models that First 5 Alabama has been very influential in working with. So with the Alabama Department of Early Childhood Education, these are all things that functioned from an infant and early childhood mental health lens. So nurse-family partnership, which you heard earlier is an evidence-based model. Parents as teachers, both funded through McV dollars, which come through the Department of Early Childhood Ed. We have coaches, infant toddler coaches that are all trained and programmed for infant toddler care. And we've implemented conscious discipline in Devereaux statewide. So all of our first class pre-K programs are in a statewide conscious discipline implementation, which is the first in the country. We are now involved in a research with Child Trends to measure cortisol levels in children in classrooms who are actively implementing conscious discipline. So we're doing taking saliva samples from children at the beginning of the year and then at the end of the year, and also periodically through the year to see if conscious discipline practice actually reduces cortisol level, which tells us that it will reduce stress levels in those children. We're also doing it with teachers as well. So we're doing that in partnership with Conscious Discipline and Child Trends. The Alabama Partnership for Children, which is where Sir Ellen is housed, also houses our director or lead person in strengthening families. This is something that we've implemented statewide as well. Of course, First Five Alabama is housed under the nonprofit of APC. We also have the Alabama Parent Leadership Network, which Georgia has as well. And we're also implementing the Growing Brain. And we're implementing the Growing Brain through Alabama Partnership for Children. We have added a Growing Brain Train the Trainer event that will be held in January, which is part of our Workforce Development Initiative, where all of our infant and early childhood mental health consultants will also be trained trainers in the Growing Brain, which will allow us to sustain that work and that workforce development activity throughout the state. And then we also have Help Me Grow, which is our parent navigation system. And I'm not sure if Georgia participates in Help Me Grow or not, but this is where every region, Help Me Grow region, has access to a care coordinator. And so parents, teachers, pediatricians, whoever can call the Help Me Grow care coordinator, and that person is tasked with making sure that that child has a current ASQSC on file within our statewide database, and that the parents or the teachers or the agency are connected with services for the child, family, or that agency. They also help to refer families and agencies for infant and early childhood mental health consultation. And then the Alabama Department of Mental Health, which is where our new infant and early childhood special programs is housed. Through here, we have the DC 0 to 5 trainers. As of January, we will have 4 trainers. I know earlier I said 2, but as of January, we'll have 4 trainers to continue implementing this and to sustain it. Again, the Growing Brain trainers will be housed in this program. FAN, which is facilitating attuned interactions, and then the Infant Mental Health Foundations and Child Parent Psychotherapy. All of those workforce development pieces will now come through the Infant and Early Childhood Special Programs. And that is a quick snapshot of everything that we're doing, and I'm sure you have questions.
Excellent. We do. Is it Representative?
It's a lot of stuff, and it can get convoluted, and it's hard to wrap your head around it. So I'll go ahead and ask your questions.
Representative Oliver.
I think this is very impressive. This is very helpful to me. I'm focusing on your slide 0 to 3 financing policy project. You say that Alabama was selected by 9 other states. Selected by whom? And
0 to 3. 0 to 3 is an international organization. They're an advocacy organization. They have offices in D.C. How else would you explain it, Sarah Ellen?
And is Georgia one of those, or do we know?
To my knowledge, Georgia was not in the last cohort, and I know they weren't in the first cohort. That does not mean they can't apply. Yeah.
Okay.
Eligible to apply. It's a technical assistance grant, which means you don't receive money, but you receive training throughout a year.
And in your first slide, infrastructure timetable, Alabama was awarded launch along with Georgia. Where did that grant come from?
That was a SAMHSA cooperative agreement grant.
Substance abuse. turning to your 0 to 3 financing policy, your goals are to implement the diagnostic classification codes. Have you done that yet?
So what we're doing right now, we're creating the crosswalk, what we call a crosswalk, that will crosswalk the DC 0 to 5 to the DSM 5, so that the current diagnoses that are being used crosswalk over for billing purposes. But then we're also crosswalking over to the ICD-10 and CPT codes, because in Alabama we use CPT codes
And
for
you can
Medicaid
do that
billing.
without CMS doing anything
Yes.
extra.
Yes.
And the main focus of that expanded Medicaid coverage, is what I'm hearing,
Yes.
is to expand the sessions for prior to diagnosis consultations.
Correct.
And that sounds to me like it would be very helpful. Tell me a little bit more about why you have adopted that strategy.
So, we know that there are states that have implemented this, Minnesota being one of them. I think Michigan has, and I want to say there's one other state, and I can't recall it right off the bat, but Minnesota has been on the forefront of expanding the number of visits before creating a diagnosis. And they've also, they're on the forefront of utilizing the DC 0 to 5 as part of their diagnostic criteria. So the evidence shows that a child cannot be diagnosed, a child under the age of 5 cannot be diagnosed in a 1-hour visit because it is very complicated. We need to look at the relationship between the child and the parent. Is it an attachment issue? Not an attachment disorder necessarily, but a relationship issue to where child-parent psychotherapy or ABC or some other attachment-based model would work for that family. Is it some other environmental issue where we need to get the family connected to wraparound services to address that issue? The DC 0 to 5 is also allowing us to identify autism early, within the first 18 months. So we do have criteria for early diagnosis of autism. It is a temporary holding diagnosis, so it may not be autism, but it's a holding diagnosis, which in some states qualifies them for early intervention services.
And you have to have the Medicaid Department cooperation to do all this discussion and work, I'm assuming.
Yes.
Madam Chair, this is the kind of thing that we need to, I'm listening, trying to listen carefully and pick up what are the elements that I think do already exist in Georgia, and what are the elements that are missing to move us to consider recommending this kind of process for Medicaid expansion.
So the Alabama Department, the Alabama Partnership for Children several years back did a landscape, and if I would have thought I would have brought it, but it's this infant and early childhood system of care, the entire system. So home visiting, education, health care, for child wellness. And when I got here in 2015 and I was looking at that, I thought, where's the mental health section? Where's the mental health system? And why is there such a gap? And that's what led us to do the landscape survey to see what mental health services were being provided outside of home visiting. And so now we're working on, and then if we get the next round of V5 money from PDG, our hope is to update that system
What's
of
PDG?
care, the
Kellogg?
preschool development grant. It's a federal grant through HHS.
Well, this is very encouraging. This is a roadmap for some elements of expanding services for that population. Thank you very much. Very helpful.
Any other questions?
Any other questions or comments? Yes.
Madam Chair, I got a
Chairman
question
Dickey.
maybe for you or for, in listening about the Alliance for the Advancement of Infant Mental. Georgia's in the process of discovery, but what agency or would be taking that on in Georgia?
So it can come under a nonprofit. We chose to house ours in Alabama Partnership for Children because it already held a nonprofit until we could, the association could stand alone as its own nonprofit. So What we did was, because of our unique situation where we have strong partnerships and relationships with all of the state agencies that serve children and families, we brought them all to the table, and everyone agreed. They signed an agreement that they would participate as founding partners of this association. And each year we update their agreements as to what they're going to provide in kind to the support of the association. So the W.K. Kellogg grant gave us the money to startup money. So it was our Kickstarter. But you could house it anywhere. The association, the Alliance really recommends that it be a nonprofit, or that the association within the first 2 years of forming become its own nonprofit.
Okay, thank you.
Okay. Any other questions or comments? You've given us a lot of information. Congratulations, first of all. I will tell you that the two things that kind of stuck in my mind were that Alabama and Georgia were both awarded project launch in 2014 at the same time, 5 years ago. And while Georgia has done a lot, we are surrounded on the map. That's the second thing when I look at this map and see that we are still in the discovery process. So we need to find out what we can do.
Can I circle back around for
Certainly.
where our chairman of the Ways and Means Committee is also our state representative for Tuscaloosa. And so when we were able to share preliminary data with him on the positive child outcomes that we had from mental health consultation through Project Launch, he wanted to sustain that. And so he brought it back to the state legislature. And that's when they created a line item for $500,000 to get us started on that expansion piece. So it was really our state legislature that found a way to do it.
Excellent. That's good to know. That's also very good to know. Well, I want to thank you. I know we're going to be in contact more as we begin to, not only from this committee, put together our findings, but I would hope as a state that we find the ways to ask more questions and
Absolutely.
see what we can do to
All right.
to complement one another, I would say, and the other states that are surrounding us right now as well. So,
Well, we have lots of friends out there, and like I said, being part of the Alliance, an affiliate of the Alliance, has really opened doors for us to be able to share resources. When we did the DC 0 to 5 Train the Trainer, we shared the cost of that training with 3 other states. So we were, one state was able to find a venue at no cost, and we all pulled our resources together and sent our trainees to that training. So
Excellent.
pooling resources.
excellent. I'm sure there'll be more ideas like that we'll want to talk to you about a little bit later as we begin this journey. Because as I understood, it was stated earlier, this is a journey. It really is. So, thank you, and thank you for
Thank you.
traveling here today. And
Thank you for having us.
giving us this much time. There are a few other people in the room, I think, that have asked to make a few comments. So if you just want to move toward the microphone. It's my understanding, too, so let me go back to our agenda one more time. So the CMOs, as you can see, the last thing on the agenda was for us to hear from our CMOs. The CMOs are not going to be speaking to us today. So we will hear from some others that are here that have some great ideas. Please. Oh, I'm so sorry, Jesse. I'm so sorry. I didn't see you back there, I thought. So, great. Excuse me, Jesse Weatherington.
Thank you, Madam Chair. Sorry, I
Yes.
was hiding in the back there. I'm Jesse Wellington. I'm here on behalf of the Georgia Quality Healthcare Association, which is the trade association of the Georgia Managed Medicaid plans. So that is AmeriGroup, WellCare, Peach State Health Plan, and CareSource. Hate to come to a committee unprepared, but the committee reached out to our various members last week, and they reached out to me late last week to want to come and just, say we were here, we were following the work of the committee, but wanted to provide some clarity around, I think, what the difference between EPSDT covered services that are currently funded under Medicaid versus a state plan covered service, and kind of what the process was to make a change if the state does want to go in that direction. So I think there was some clarity that was requested and communicated to me around that. Otherwise, I would ask for the committee's forbearance to allow us to give you any more detailed responses, particularly around the interaction between CMOs and Babies Can't Wait, for example, in writing after the fact. So if that is appropriate, Madam Chair, I can go ahead and treat on that topic if that is what you're interested in hearing.
Surely, that'd be great.
So EPSDT is early periodic screening, diagnosis, and treatment, and so that's distinct from a state plan covered service in a different way. So the state plan is the contractual agreement between CMS, the federal agency, and the State Department. So in Georgia, that's DCH, the single state agency for Medicaid. And so that's the broad agreement about what services they will cover and what services CMS will reimburse for. EPSDT is a little different. Congress passed that program in 1967, pretty much immediately at the outset of Medicaid, to allow for coverage of services because Medicaid has to treat what is deemed to be medically necessary to ameliorate or cure a child's condition or a member's condition. In this case, we're talking about children. And so even if those services are not necessarily covered under the state plan, they must be provided under EPSDT if that medical necessity definition is met. And those are done on a case-by-case basis. So it is hard to make a generalizable statement about that. What I would like to do is take some time to go back to each of our individual plans and see how that works, because we're subject to that as well as managed care organizations. But again, those are done on an individualized basis with review of medical necessity as proved by that child's care provider, be it medical, behavioral health, therapy, things of that nature. So that is currently being done in terms of the state plan services. So that would be a decision that would need to be made, jointly by the state of Georgia and its various instrumentalities, be it DBHDD, DCH in this example. So they would need to make a determination about what services they wanted to cover, what codes, what the diagnoses or support would need to be to support those codes in an evidentiary manner, so that CMS will be there at the back end to provide you with that federal funding after the fact and allow for coverage. At that time, you would need to do state plan amendment. It would go through the typical approval process that you see now with any kind of change to Medicaid. You have to do a public comment period. There has to be a resolution by the DCH board, and then that would be covered under the service should CMS deem that to be approved and under the appropriate under the auspices of the Medicaid program. And so, there are some of these things that are being covered today. Again, it's on a case-by-case basis. It's not the state's policy. So, once this process is played out, the CMOs in particular, we will do what is asked of us by our contract owner. We'll do what's in the contract. We would just ask that it's funded and appropriate, and that CMS has deemed that to be acceptable and reimbursable under the plan, and that those would flow through, of course, to the rates. So I hope that makes sense. Medicaid financing is a convoluted topic, obviously. But other than that, if there's any particular questions, I'd be happy to take them, address what I can now, or take them back to my respective companies to see what they're currently doing.
Thank you. And I'm so sorry I didn't realize you're back. There's a post between you and me that was hiding you, I think. Representative Oliver.
Medicaid financing as a complicated subject is an understatement, and probably you're the person in this room who knows more about it than anybody. So I'm going to take advantage of your knowledge. What I heard is that Department of Medicaid, Community Affairs, has an opportunity to expand its codes, to provide more coverage, at least on the issue of consultation. But you have to do that based on, you mentioned a partnership with behavioral health, or you have to do that based on some evidentiary development of programmatical need, or how do you get to the point of making that decision to amend your plan?
So good question. And it's, different for different services and different conditions that a member may need. So
we're talking about infant, early, toddler, emotional health.
Right, and so those are currently going to be served both under DBHDD programs that are both state funded and jointly state and federally funded, and there's a DPH component, because you heard about Babies Can't Wait and Children First. Those departments, and this is something that we struggled with when we were reorganizing the state HHS agencies about 10 or 11 years ago, was you had the DHR model where everything was integrated. That wasn't working well, so the legislature and the governor at that time period made the determination that they needed to break up the agencies to be a little bit more focused on what they were doing. That's the current situation that we're in today with DBHCD, DCH, DPH, DCAL, education. For certain aspects of services covered under the state plan, for example, children's emotional behavioral health on 0 to 3, addicted disease services for adults would be another example of this. It's not analogous to this, but it works the same way. DBHDD is the owner of that program's policy determination, and so they work in concert with DCH under the direction of the governor to determine what services they want to cover at what level. DBHDD and DCH would need to agree on what that is, and then they would run that through DCH to get the federal funding.
Have
for
they
it.
been asked to do that?
I can't comment on that. I do not know the answer to your
And
question.
if they were asked by, are the only entity that can ask them to do that, them being asked behavioral health to develop a need assessment for emotional health for children, does it only come from the governor, or could it come from the General Assembly also?
I don't know that it'd be appropriate to ask me that question. They'll follow the law. They'll do what's in the budget, and we'll do what's in our contracts. But I would say, based on my experience as a legislative staffer working in the budget office, working at DCH, you would need to do that in concert so that everybody was eyes open going into the process. Certainly, you would need to have a fiscal analysis on what that would end up looking like, and make the determination about whether or not through the budget process that's something that the legislature would want to support. It sounds like there is support for that, but I don't believe that there's any single entity that would need to arrive at this decision, but it's something that everybody would need to arrive at in concert.
Based on your experience, do you have an opinion about how long such a needs assessment could or should take from behavioral health?
That's a good question. I don't want to be in the position of speaking for a department. I had that responsibility for a number of years. I don't anymore. From my client's perspective, as a managed care organizations, we will be happy to work with whatever group or panel, task force, state agency partner we're asked to do it, and do it in all due speed.
Thank you.
Any other questions or comments? Not seeing any, I want to thank you. You used a really important word there, concert. That's really where we have to go with this, I think, is to see how we can all work together, without a doubt.
Well, thank you. Appreciate the opportunity to come and speak with you. Sorry we didn't have a more detailed presentation for you, but if there's any more particular specific items you'd like some clarity on offline, I'd be happy to work with you, work through Sarah to get that to the committee before your report is due.
Thank you so much.
Thank you.
Okay, now, any other comments?
Thank you, Representative Dempsey and members of the committee, for the opportunity to speak to you today. I'm Ariane Weldon with Georgia Family Connection Partnership, and I serve as the director of the Get Georgia Reading campaign. By looking at factors across birth through the third grade continuum that influence a child's ability to read, we find that social and emotional development in the early years is linked directly to success in the early grades. This matters because understanding this link provides important clues to inform solutions. So I want to share some informative research with you that will lead to some recommendations. Number one, in the earliest years, problems with social and emotional development often result from problems in the child's primary attachment relationship. Number two, universal brief postpartum nurse home visiting designed to assess risk and protective factors, provide supportive guidance, and connect families with community resources is shown to, 1, reduce rates of child emergency medical care through age 2 while being cost beneficial to communities at a ratio of $3 saved for every dollar invested. Also, it is shown to improve infant and maternal health outcomes, including maternal mental health, increase positive parenting behaviors, and increase rates of participation in quality child care. Number 3, quality child care is significantly associated with reduced risk of behavior problems among children 1 to 5 years of age, of mothers who have been diagnosed with maternal depression. Also, left untreated, children who experience early behavioral problems can develop more serious mental health conditions that impact their learning and achievement. On a related note, language development is the foundation for social, emotional, and mental health development and is dependent on the quantity and quality of child-directed language and input and engagement provided by caregivers beginning in infancy. This matters because problems with development of language skills are associated with increased risk of hyperactivity and attention, conduct problems, and emotional symptoms throughout middle childhood and adolescence. And the findings point to development of early language skills as a useful target to prevent development of mental health problems. On a related note, the prevalence of previously unidentified language deficits in children ages 5 to 13 who are determined to have emotional and behavioral disorders is 81%. Among school-age children, lower language skills are linked with higher rates of aggression, and higher language skills are linked with higher rates of academic engagement. And compared to their peers, children with poor language skills at age 5, when followed 11,000 children up to adulthood, are 4 times more likely to have reading difficulties in adulthood, 3 times more likely to be diagnosed with a mental health disorder, and 2 times more likely to be unemployed. I want to take a moment to focus on our preterm birth population. This might be some places to identify some other recommendations. Georgia's preterm birth rate is on the rise. It's up from 10.7% in 2013 to 11.5% in 2018, and children born preterm are at significantly higher risk of emotional and behavioral disorders compared to their full-term peers. Rapid brain development begins in utero, extends throughout a child's first years of life, and is shaped by caregiver engagement, which is essential for language learning. I made that link for you earlier. If this developmental process is disrupted by preterm birth, problems with language development are likely. Newborns admitted to a neonatal intensive care unit are 6 times more likely than their counterparts not admitted to a neonatal intensive care unit to develop disorganized attachment, which is an indicator highly predictive of later mental health disorders. And also for this population, they are significantly more likely to be diagnosed with ADHD, almost 6 times more likely if it's a very preterm baby. And a couple of other research points. It's estimated that between 24% to 35% of parents who have infants admitted to a NICU experience significant stress and depression symptoms that persist up to 1 year after discharge. And also research also shows that parents of infants admitted to a NICU describe even shared reading practice with their babies as a positive experience, a source of comfort, and a practice that helps them cope. And participating in a NICU shared reading program in NICU as NICU practice significantly predicted the likelihood of that engagement later in childhood. And finally, from the research, kangaroo mother care for preterm and low birth weight infants has been shown to have significant long-lasting social and behavioral protective effects 20 years after the intervention, including reduced school absenteeism, hyperactivity, and aggressiveness as young adults. So please consider these recommendations informed by the research. Number 1, continue to invest in children first, Georgia's single entry point into all public health services and a wide range of community programs for children birth to 5. It's the primary way for children born in Georgia to be identified for conditions that would otherwise result in poor health and development. Number 2, develop and support efforts that increase the numbers of infants and toddlers who receive language nutrition from their parents and caregivers. Number 3, provide supports and opportunities for parents of infants admitted to a NICU to provide shared reading experiences with their babies. Could look at expanding a current effort practiced at the Grady Hospital NICU called Shared Reading for NICU Babies. Number 4, support use of kangaroo mother care, which is continuous skin-to-skin contact between parents and infants for preterm and low birth weight infants to improve physical, social, and emotional development. Number 5, inform parents and caregivers about developmentally appropriate language and communication milestones and how to promote their development, recognize difficulties, and seek additional support when necessary. Number 6, expand child-parent psychotherapy. You heard about that earlier. training for mental health providers. Child-parent psychotherapy is a dyadic, relationship-based treatment for parents and their young children aged birth to 5 that aims to help restore normal developmental functioning. And number 7, support implementation of infant and early childhood mental health consultation. You heard about that earlier. And finally, promote and increase utilization of the Planning for Healthy Babies program, which is our family planning waiver in Georgia. It was developed by the Georgia Department of Community Health and available statewide, and its focus was on helping reduce the number of low birth weight and very low birth weight infants. Thank you.
Thank you. And thank you for the work you do. Are there any questions?
Thank
Okay,
you.
Chairman
Thank-
Dickey.
I got a question about our preterm birth rate and low birth weight. I know Georgia's high, and you said it's on the rise. You want to speculate why it is? I mean, I think I know, but I'd love to hear your thought on that.
Sure. Generally, the number one reason is having had a very preterm baby, but other risk factors include smoking, alcohol use in pregnancy. We've seen relationship with stress, so you see some things around like group prenatal care that have shown to reduce stress during pregnancy. And so those are some of the other linkages. It's also actually the reason why we created the family planning waiver. It's called Planning for Healthy Babies in Georgia, to help provide access to prenatal care supports, and then also provides a resource mother for those who've had a very low birth weight baby to help improve spacing in between.
Yeah, those babies are very expensive and long-term, short-term, lots of services. And I just think we do need a lot of preventive and services for those at-risk mothers and doing that. So thank you.
You're welcome.
I don't see any other questions, so thank you so very much. So, we are coming down to closing down this study committee in just a little bit. I would ask among the committee, I want to thank each of you, first of all, for the investment you, along with all who have presented and attended, have made in these 5 meetings, but also as we focus on what our original charge was. I really think we've done a great deal of work to expose a very serious concern that in so many ways is cost-saving and life-giving, which is a goal that I think we all probably arrived in the legislature with. So I'd like to just ask among the committee if you have anything after listening to this, and you can tell us more later in the next few days. I know we're getting ready to all go have a lovely Thanksgiving, hopefully, and catch our breath. But as you step away, by next Tuesday, I'd really appreciate if you get in touch with me or Sarah or my assistant Lori and let us know if there are some concerns that you have or some great big ideas that you have to share with us as well. But if anything right now, if there's anything that you feel you need to share or talk about, we have a few minutes, and glad to hear that. Some ideas to challenge us to help Sarah get ready to write an excellent report and summary of these sessions. So I'll look to you if you need to. Oh, I know you would. Thank you, Representative Oliver.
One of the Emory community psychiatrists told me about a 4-year-old who was hospitalized at a private psychiatric hospital who was in DFACS care. He'd been there 4 or 5 months, a 4-year-old. Now that tells me that there were a whole lot of cracks out there. And that the state of Georgia, who had a responsibility to this child, was spending the maximum amount of money possible under any scenario in Western civilization. So I'm very interested, as you've heard me, try to find the leadership in behavioral health and Medicaid to redo their codes that would at least allow 5 consultation visits, pay for, to assist a very young child and her parents get some Medicaid support. It's the lowest state match, and it's under CHIPS and the managed care organizations. We have a contractual opportunity to enforce that providing of services if it's properly billable.
Thank you. Thank you. Chairman Dickey.
Madam Chair, I'd just like to say thank you for the opportunity to attend these meetings. I've learned so much, and it's one of the areas that I have not spent a lot of time and known a lot of expertise, but it's really opened my eyes to a lot of things. And thank you members of the committee. I've learned a lot from them, and just kind of refocused a little bit of my attention on a real need in this state. So thank you for this study committee.
Well, thank you for all that you do. We want to help you have children that are prepared to enter our K-12 system. Okay, well, I will tell you that as I sort of reflect on it, one of the big things that I think we've got to do is we've got to find a way to pull many of our agencies together. Certainly conversations with our governor and other leadership in our state. But I do not think that there is, I have not seen a lack of desire to tackle this challenge. It's just how we get there. So I think as we look at the report, hopefully we'll find some strong language that calls that to happen and leads us to help challenge them to use all of the tools and abilities that they have, but in a timely fashion. So not this is an idea and we want you to think about it for a long time, but pretty quickly. I was quite impressed by Alabama and what they've done in their 5 years. And I think we need to remember that and reflect upon it and know that if Alabama and all of our other neighbors can do this, we can too. So, Sarah, thank you so much. And Betsy, thank you always for being here with us. Appreciate you. And I'll just say thank you so much. I have learned so much too as well, Robert. It's been a very, very good discussion and a beginning of a long-term discussion and journey, I think, for Georgia's children and Georgia's stability. Thank you so much. We are dismissed.